informação entra numa base de dados e a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. And I also treat minor ailments. I have a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem, you try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
how do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
Good morning, ladies and gentlemen. Health is not just a fundamental human right. It is the only fundamental human right that is necessary for the enjoyment of all other human rights. So when 2 or 3 people are gathered in the name of health, we know that God is in our midst. I would like to call on Dr. Aaron Christian to place us in the hands of God for this conference.
Thank you. Shall we humbly be on our feet? Shall we pray? To the eternal Most High God, we thank you for health. We thank you for the gift of life. And we thank you for this program. We commit these wonderful sections you've helped us put together, that at the end of it all, we will all be blessed and improve health for humanity. In Jesus' name we pray with thanksgiving. Amen.
Thank you, Dr. Aaron Christian. Because health is so important, we have been looking forward to some of the key figures in the health sector to chair this function. We had penciled the Director General of the Ghana Health Service, Dr. Samuel Kaba Akoria. Unfortunately, we received word that he is attending another and an equally important assignment, and I have been made to understand. Thank you. I have been made to understand that he has sent someone to ably represent him. He is in the person of the Deputy Director General of the Ghana Health Service, Dr. Emisa. If Dr. Emisa is here, we want to acknowledge you. The club is not hard enough. Thank you.
Thank you very much, Mr. MC, and good morning to us all. Good morning.
Good morning.
Wonderful. So I'm glad we are all awake. Distinguished guests, our esteemed colleagues, well represented here, ladies and gentlemen. In fact, it is an honor for me to be here for this program this morning. Not just that, but to have been asked by my boss, Professor, that's the DG of the Ghana Health Service, Professor Samuel Kaba Akoria, to represent him and to chair this program, which he also deems very, very important. In fact, it is a conference that, as a service, we are happy to be part of. So let me start by saying that today we gather here under the theme, Advancing Evidence-Based Innovation for Strengthening Health Systems in Africa. This is a theme that resonates deeply with aspirations and imperatives of our times. Let me add that this has been made possible also by the Doris Duke Foundation, which is a foundation that had been set out by a philanthropist and adventurer. So Doris Duke was a philanthropist and adventurer, and she set up this foundation in 1996. And what was her aim for doing that? She loved traveling, she loved adventure, so she would go around, and as she did that, she was always looking at improving wherever she found herself, improving the lives of people there, including the health of the people there. So that is how come she actually left a written will, which said that she would love, or her foundation should be used to support innovations in health. So if we find ourselves here, it is because we have a foundation by Doris Duke which supports what we are doing. And the beauty of it is that it is a written guide. So what we are doing here is documenting what we can do or what we have been doing to improve our health system. So I'm not surprised that we are getting this funding from the Doris Duke Foundation to support this. And I'm particularly happy for this collaboration between the service and RIPS, which is the Regional Institute for Population Studies at the University of Ghana, because it is aimed at harnessing research findings to inform or shape our health policy. We always say that, yes, we have the interventions, we are intervening, doing so many things in the area of health, But as to whether they are making a change or not, I think some of these things will bring it up, or it will bring it to light. So we share the things we are doing, and then we share the innovations and share how it has improved. And then through these lessons that we share, we are able to learn, and we are able to also kind of imbibe some of the best practices that we see around. So some examples that I would want to bring to light this morning is the fruitful collaboration between the Ghana Health Service and RIPS in implementing the CHIPS Plus program. It is an initiative that was designed to address a long-standing implementation challenge within the community-based health planning and services system. We have its founder or originator here with us in this room, our own very good Professor Awuno. I'm sure at the right time, he will be called to give us insights into his works and how CHIPS is the bedrock of what we do currently in Ghana. And this is some initiative that was started as a pilot when he was a director of the service somewhere in the Upper East region so many years back. I think this was around 1996. So I'm not surprised that the funding was possibly from the foundation. I don't know whether that is what it was in 1996. But looking at the history of the foundation and when CHIPS started, I want to believe that it possibly got some support from there. Maybe we'll hear more of that. Similarly, I'm told the Acute Care and Emergency Referral Systems project has benefited greatly from a RIPS input. So RIPS was pivotal in its evaluating and refining the program. And today we know that there have been some improvements in our emergency referral system. So ladies and gentlemen, I'm particularly excited about the broader implications of our work together. So not just showcasing what we are doing, but how it has improved or influenced what we do and the outcomes or the impact it has created within our healthcare system. I will not say too much this morning. I want us to listen to others and also see where we as policy makers, we as researchers, we as health staff come together to ensure that we improve the work in our health system. Thank you very much.
Thank you very much, Dr. Emisa. That shows that you have already accepted the role to chair the function. Let me just say that this conference brings together an assemblage of some of the finest brains in this country who are working to improve access, both geographically and financially, to health. So I would like to, before I call on the organizers, the Regional Institute for Population Studies, which is hosting the African Health Initiative Community of Practice, which is graciously funded by the Doris Duke Foundation, to walk us through what we expect these 2 days, especially today. Permit me, just give me half a minute to acknowledge the presence of the people who have been invited to this meeting. We have the country director, Care International. If you're here, you are warmly welcome. The country director, Country Relief Services, the director, Christian Health Association of Ghana, the director, Council for Scientific and Industrial Research for Scientific and Technological Information, the ambassador, Embassy of South Korea, the president, the Ghana Public Health Association, the government statistician, Ghana Statistical Service, the country director, GIZ, the country director, International Growth Center, the country representative of JICA, the country representative of COECA, the country director, MasterCard Foundation Center, National Coalition of NGOs in Health, the national director, World Vision International, the chairperson, National Commission for Civic Education, the Director General, National Development Planning Commission, the Executive Director, National Population Council, the Chief Executive Officer, National Health Insurance Authority, the Country Director, Population Council, the UN Resident Representative in Ghana, the Country Representative, UNFPA, the Country Representative, UNICEF, the Country Director, World Health Organization. I was thinking somebody was going to say who. Yes, who? The country director, who? The country director, the World Bank, and the country director, the World Food Program. For those who have already arrived, please, you are warmly welcome. I'll now call upon the director of the African Health Initiative Committee of Practice at the Regional Institute for Population Studies here at the Hill of Knowledge, Professor Ayaga Agula Bawa, to come and tell us why we are here and what we should expect. Professor Bawa, if you're here, please the mic.
Good morning, everyone, and welcome to this morning's program. The Director General Ghana Health Service, the Vice Chancellor, the Pro-Vice Chancellors, Academic and Student Affairs and Research, Innovation and Development, Provosts, Deans, Directors, and Heads of Department, Faculty, Staff, and students, our development partners, the media, invited guests. It's a pleasure this morning, an honor to stand here to briefly present the purpose of this conference, which is on health systems innovation here at the University of Ghana. The conference, as already indicated by our able MC, is a joint activity between us, the Regional Institute for Population Studies, the Ghana Health Service, and the idea is to to create a platform for researchers in the field of health, policy makers, practitioners, and young scholars in particular, to come and share ideas to advance knowledge on health systems and some of the innovations that are happening in the field with the aim of strengthening health systems on the continent. As you are all aware, health systems worldwide are facing challenges that demand creative, sustainable, and impactful solutions. Here in sub-Saharan Africa, the complexities are compounded by issues such as limited infrastructure, workforce shortages, and the double burden of communicable and non-communicable diseases. These challenges require our collective intellect, collaboration, and commitment to drive transformative change and to make sure that these are brought to bear on improving the systems. Over the next 2 days, we will engage in vibrant discussions and share groundbreaking research and showcase some of the success stories that are happening across our own country and beyond. I'm therefore thrilled to share that the conference is going to be presenting over 50 papers that will be presented by researchers, policymakers, and practitioners from about 15 countries. The papers span diverse themes such as digital health, universal health coverage, community health, and health systems. Some of the innovations we look forward to hearing are geospatial tools, mobile applications, machine learning, and telemedicine to improve healthcare delivery in our country and on our continent. The purpose, therefore, is threefold. First, to highlight innovative approaches and best practices that have shown measurable improvements in health outcomes. Two, to provide a forum for interdisciplinary collaboration where ideas can be exchanged and new partnerships formed. And three, to inspire the next generation of health systems leaders by offering capacity building and networking opportunities to our young and upcoming researchers in the field of health. Following the completion of the conference, we will publish a comprehensive report, a book of abstracts, and learning newsletter that will document some of the innovations and lessons that will be showcased here so that the wider community can benefit from that. As we proceed, we anticipate that all participants will actively engage, ask questions, and share some of your experiences. The invaluable contribution will undoubtedly shape the outcomes of this conference, and more importantly, the future of health systems in Africa. So let me take the opportunity to ask that as we look at these innovations, please share knowledge and let's share a bond of friendship and community. So on this note, I want to thank you and wish you all a productive and impactful conference. Thank you.
Thank you very much, Professor Bauer, for your introductory remarks. Advancing evidence-based innovations to improve health systems. Why do we need to improve the science? What contribution does research make to policy? Maybe some of you know, but maybe some of us don't. But that would be the responsibility of one of our own, Professor Felix Ankuma Asante, who is the Pro-Vice Chancellor here at the University of Ghana, responsible for research, innovation, and development. He will tell us, he will give us a peek into the value added by research for policy making. Professor Asante.
The Director General of the Ghana Health Service, the Pro-Vice Chancellor responsible for academic and student affairs, the Director of the Regional Institute of Population Studies, keynote speaker, provost, deans, directors and heads of department, faculty, staff and students, development partners, distinguished guests, ladies and gentlemen. Good morning once again. It is a pleasure for me to make a few remarks at this important conference on health system strengthening and innovation. Coming from an office that is responsible for research, innovation, and development of the University of Ghana, you can imagine my joy in seeing programs that enhance interest in research, and especially when academia is interacting with policymakers, and that is what we want to see as a university. In line with our new strategic plan of the university 2024 to 2025, it is our goal to have more collaborative and impactful research. The vision of our research strategy as a university is to be an institution of choice for collaborative research and industry partnership, with a mission to promote the University of Ghana's global impact through enhanced collaborative research and partnerships, knowledge generation, and dissemination. The University of Ghana Research Strategy, which was launched in 2024, has 7 priority areas, and these are infectious and non-communicable diseases, 2, food production and processing, including improved approaches to breeding, 3, transdisciplinary research into climate change adaptation, 4, development policy, poverty monitoring and evaluation, 5, politics, sociocultural change, mobility and development, 6, creative arts, education and communication information literacy, and 7, the 4th industrial revolution tools, where we talk about artificial intelligence, data science, machine learning, amongst others. And in the speech of the director, you can identify quite a number of the priority areas of the university in what RIPS and Ghana Health Service are doing this morning. And we congratulate them for organizing such a function. The Research and Innovation Directorate, which is one of the units that reports to me, serves as the research arm of the University of Ghana, with a mandate to foster a vibrant research environment and develop strategic partnership that advance scholarship and innovation. One of the Directorate's core responsibilities is to coordinate research efforts across the university. This involves developing and implementing the university's research policy, ensuring effective distribution and efficient use of research funds, and setting standards for high-quality research output. By absorbing the functions such as the formal Research and Conferences Committee and the Publications Committee, the Directorate has streamlined research administration, enabling a more cohesive and collaborative approach. In the realm of development, the Directorate plays a transformative role. It is tasked with fundraising for research, establishing systems for ethical clearance, and facilitating the registration, patenting, and commercialization of intellectual property. These efforts not only enhance the university's research capabilities, but also contribute to national and global development by translating academic findings into practical solutions. The Directorate is also committed to capacity building, and is evidenced through its services, which include grant management, support, technology transfer, and intellectual property management. These initiatives empower researchers to excel in their field and drive innovation that addresses pressing societal challenges. As we look to the future, the university commits to strengthening its role in promoting research, innovation, and systems development, as this remains a cornerstone of the University of Ghana's mission to intensify research and innovation. Its dedication to coordination and development ensures that the university continues to thrive as a hub of knowledge, creativity, and progress. In conclusion, let me congratulate the organizers once again on putting together such a comprehensive research agenda, which we will keenly monitor to see the outcomes of the recommendations that will arise out of the two-day conferences. Thank you for your attention.
Thank you very much, Professor Asante. There are a couple of dignitaries who have come that I need to introduce them as the information comes to my attention. We'd like to welcome the Provost, College of Humanities, Professor Joseph Yaro Awetori. You're welcome. We also welcome the Provost, College of Education, Professor Samuel Kujo. Prof, you're welcome. This conference is hosted by the University of Ghana, and the Vice Chancellor of the University, Professor Nana Abba Ampia Ampofo, would have loved to be here herself to welcome you as the host and the special guest of honor. But we may not be missing much because she has sent one of her able lieutenants, Professor Awandari, who is the Pro-Vice Chancellor in charge of academic and student affairs. So please put your hands together and welcome Professor Awandari, who is standing in for the Vice Chancellor of the University of Ghana to deliver the host and special guest of honor remarks. Thank you.
Thank you very much. Good morning. I believe that our able MC skipped my talk for a good reason. That's because my colleague, Professor Asante, has done justice to the opening in terms of what the University of Ghana represents. So I'm just here on behalf of university management to express our support for this program, to express our support for Prof. Ayaga and RIPS for organizing this program and for showing leadership. The University of Ghana has a distinguished record of leadership in health research, ranging from the systems level, which is what you are discussing these 2 days, all the way down to the cellular and molecular level, which is where myself and Prof. Kusi and others operate. But this university has done incredible research and capacity strengthening for health across the continent. So it is our great honor to welcome you to the University of Ghana, which, as you know, is the nation's hope and glory. And so we always take pride in leading and setting the pace for others to follow. So, Dr. Emisa, you are welcome on behalf of Director General. Dr. Awonu Williams, you're welcome representing the ministry. Representatives from Doris Duke, we are grateful for the partnership. All the representatives of all the other partner organizations, we're grateful for your collaboration. Provost, thanks for taking the time. Deans, directors, we're grateful that you are here to support. Colleagues, good morning, and I wish you a very fruitful 2 days. Thank you very much.
Thank you very much, Professor Awandari, who stood in for the Vice Chancellor of the University of Ghana to deliver the host and special guest of honor welcome remarks. We have sat for quite some few minutes. We would like to take a small break by inviting a musical interlude. And so if the artists are ready, we are more than ready for them. Thank you. Thank you very much for the very refreshing musical interlude. This is one of the very first time that I've seen that the program is running on time, which is quite unusual. There are dignitaries here who have not been introduced. It's for a purpose. They have special roles on the program. So as time goes by, we'll give them the due introduction and recognition. But let me welcome Dr. Samuel Bwachi Boateng, who is the director of the PPMED. PPMED of the Ghana Health Service. I didn't know there was now a D. Okay, but that's fine. Every day we learn. So we are talking about improving access to health using innovations and evidence and all that. We have one of the people in this country who have a lifelong commitment and a selfless dedication to bringing health services to where the people are. Ordinarily, he needs no introduction. Dr. Koku Awuno Williams, EFO. I've had the rare privilege of working with him. He is now the technical advisor to the Ministry of Health. He's a public health consultant, that's no gainsaying, and a health systems and policy analyst. But for a good reason, we would call him Mr. Chips. But we will leave that for another day. EFO, Wizo, we will call on Dr. Koku Awuno Williams to step up here and deliver the keynote address.
Thank you very much, Dr. Santua, and good morning. Welcome, all of you. Aside Prof. Awandari, everybody was wearing glasses, so I also want to wear the glasses. And I was going to wear the silver one, but I saw everybody wear the black one, so I wear the black one. Thank you. The Deputy Director General of Ghana Health Service, the representative of the Vice Chancellor, Professor Awandari, Professor Pro-Vice Chancellor, Academic and Student Affairs, Research, Innovation and Development, Provosts, Deans, Directors and Heads of Department, faculty, staff, students, development partners, the media, and distinguished ladies and gentlemen. Good morning and welcome again to this conference. Just to say that there's a lot of things happening in strengthening health system in Ghana. And today at 11 o'clock, there will be the launch of the Ghana Medical Trust Fund. For those of you who are familiar with the politics of Ghana, popularly called Mahama Care. And unfortunately or fortunately, I'm supposed to be there to also make a presentation, so I will be snappy, if you permit me, so that I can take the keynote address. But as introduced, for many of you who know me, I have a lot of passion for health system strengthening, and that has been my lifelong career. I think Professor Bawa, if you remember 2017, we tried to host the similar conference internationally across Africa. But at the last minute, we had to call it off, I think because of election or something that happened. So I want to commend you and your team for this, and I'm so delighted to be here. This conference holds a profound significance as it shines a spotlight on evidence-based innovations that have the power to transform health systems and create lasting impact. There is no doubt that health systems worldwide, and many of you know that, faces complex challenges and therefore demand bold thinking and innovative approaches. In Ghana, like many nations in sub-Saharan Africa, we contend with resource constraint, the major challenge, inequities in access to care, and the dual burden of communicable and non-communicable diseases. Now it's even such a triple burden if you look at NCDs, including accidents and injuries. These issues are further compounded by workforce shortages and infrastructure limitations, especially in vulnerable and underserved communities. Our recent data, 2025, showed that 60% of healthcare workers, mostly nurses, have intention to migrate the next 3-4 years. So we have a huge challenge of how do we ensure that the gap or the shortages are managed. The question before us, therefore, is very clear. How can we collectively address these challenges, as I mentioned, in ways that are sustainable, impactful, and inclusive? And for me, innovation is my strongest view as the answer for that. Innovations. Innovations, innovations, innovations. Every innovation, no matter how small, has the potential to ripple across generations, improving health outcomes and ensuring a brighter, healthier future for all. Innovation encompasses many things. It is not just about technology or strategy. It's about the imagination, collaboration, and an unwavering belief that together we can create solutions that are dynamic and diverse as the challenges we face. So the power of innovation therefore lies in its ability to connect people and ideas, turning possibilities to reality. In the sub-region, and for that matter, Ghana has been a pioneer in piloting innovative interventions to improve health system. And I will just share some thoughts on our country's evolving health system, with groundbreaking reforms in community-based services through 2 major programs that were implemented: the Ghana Essential Health Intervention Program, and a program for strengthening community-based health and planning services, what is known as CHIPS+, alongside other innovations in health insurance, digital health, emergency care, etc., etc. Now let me talk about the refinement and redevelopment of CHIPS, what we call the community-based health planning and services, moving from that to what we call the GHIP and then to the CHIPS+. As you are aware, Ghana's flagship community-based or CHIPS program has long served as the cornerstone of our primary healthcare system, especially in rural and underserved communities. Starting with the formative work and experimental trial that was done in Avrongo in the Upper East region of Ghana, there were several replication trials to get the concept in a non-experimental settings, including what was done in Nkwanta, what is called the Nkwanta replication, which I led in the Volta region, which is now OT region. Following this successful replication, the program was launched nationwide. And for those of you who remember very well, in the year 2000. Following several years of implementation and identification of problems associated with the national scale-up, the GHIP project was launched and implemented between 2010 and 2015 in the Upper East region again to test the strategies that can improve the CHIPS implementation. So GHIP played a pivotal role in demonstrating
how a well-supported CHIPS model could significantly reduce neonatal mortality and improve service availability at the community level if appropriately implemented with community involvement, which is key. Now, GHS successful strategies ranging from enhanced supervision and community engagement to better resource allocation provided the critical lessons that paved the way for further refinement. Now, evaluation of this project or program of 5 years implementation showed close to 50% reduction in neonatal mortality over a period of 5 years. Now, building on GHS achievement was the CHIPS Plus project, which was launched following the 2015-2016, which sought to scale up and strengthen the CHIPS model on a national level. With financial and technical support from international partners, as mentioned, Doris Duke Foundation, COICA, etc., the project extended service to more zones across all districts. Now, CHIPS Plus introduced improved community health volunteer system, reinforced capacity building exercises for community health nurses and officers, and upgraded operational governance, ensuring that the model not only expanded geographically, but also improved the quality and responsiveness to community health needs. Let me just make a few points on health insurance as one of the innovations in health system or for health system strengthening. You are aware the national health insurance is the cornerstone of our drive towards universal health coverage, recognizing that financial barriers remain a primary obstacle to accessing care. System reforms have focused on a number of things within the innovation, within the NHIS implementation. Digital integration, for instance, was key. Coverage expansion was very key. Sustainable financial models was key. And these innovations aim to integrate preventive, promotive, and curative services into a cohesive system that not only responds to healthcare demands, but also financially sustainable in the long term. When it comes to digital health initiatives, we know how technology is transforming the way health information flows. If you take our health system or structure, and the key achievements even in this area in terms of digital health initiatives, one is our electronic medical records and health information system, whereby digitizing patient records and integrating data across different levels of healthcare, Ghana is enabling health professionals to make data-driven decisions, leading to improved continuity of care. And the point is at the point of care. Telemedicine and mobile health, for instance, what we call the mHealth. Here, remote consultation platforms allow patients in remote or underserved areas or regions to obtain specialist advice without the need of long travel. And it also involves capacity building. In parallel, mobile apps and SMS service provide crucial health information, promote medication adherence, and also offer timely appointment reminders. So also is our enhanced public health surveillance, where integrated digital systems now capably track disease patterns and health trends, which facilitate proactive management and strategic resource allocation across the health sector. Madam Chair, these digital innovations not only elevate patient care at the community level, but also dovetail with the other health system components, where creating a more agile and responsive healthcare network. And finally, let me also talk about emergency health system innovations. A modern emergency health system is indispensable, particularly in a landscape characterized by rapid urbanization and emerging new health threats. Ghana is making strides significantly in these areas as well. Digital response coordination, where new platforms like emergency responders with hospitals,
via real-time data exchange and GPS tracking. This ensures that, for instance, ambulance dispatch and patient transfers are executed with greater precision and speed. Then we also have the modernized ambulance services, where integration of digital dispatch system into the ambulance operation supports faster communication between field teams and healthcare facilities. There is also the enhanced pre-hospital care protocols, where investments in training for emergency medical technicians and the deployment of mobile digital tools during triage are essential steps in ensuring that patients receive rapid and effective care even before reaching advanced health facilities. Lastly, Madam Chair, interoperability with other digital health platforms. It's also one of the innovations that we have, where by connecting emergency services with broader digital network, emergency response efforts are better informed by real-time patient data and health records during crisis. So these refinements, Madam Chair, underscored Ghana's commitment to ensuring that emergency health systems are nimble, technology-driven, and fully integrated within the national healthcare framework. In concluding, Madam Chair, ladies and gentlemen, Madam Chair, Ghana's strategic innovation across its health system illustrates a comprehensive approach to overcoming traditional challenges through evidence-based reforms and modern technology. The evolution of chips, for instance, marked by the transition from GHS to CHIPS Plus, epitomizes how sustained investments in community-based care can lead to significant public health gains. When combined with advancement in digital health, progressive health insurance reforms, and robust emergency response system, Ghana is well on its way to constructing a resilient, equitable, and efficient health system capable of addressing both current needs and future challenges. I look forward to engaging over the next 2 days on this platform for interdisciplinary collaboration, knowledge exchange, and mutual learning, where we will share experiences, showcase best practices, and explore how successful health systems innovations can be adapted and scaled to suit unique contexts. May the conversations and collaboration we begin today pave the way for impactful solutions that will resonate far beyond the walls of this conference hall. Thank you for your attention. Thank you.
Thank you very much, Dr. Kokua Williams. Today he spoke out of character. He usually doesn't come to deliver speeches prepared. He speaks extempore. I'm sure the organizers must have impressed it upon him to kindly put those ideas on paper to guide our deliberations. Thank you very much. Research has a number of constituencies. Maybe I think there are 4. We have us, the beneficiaries of research. We have those like the University of Ghana who do the research to come out the evidence. Then we have the policymakers who create a space for research to happen. And then we have those who provide technical and financial support to carry out research. And the African Health Initiative Committee of Practice program is graciously funded by the Doris Duke Foundation. It is my privileged pleasure to invite the Chief Program Officer of the Doris Duke Foundation, Ms. Morris D. Knighton, to give us a statement, a word of encouragement, if she's here. Okay, so we may skip that and then take remarks later during the program. So she was to launch the official, okay. Oh, oh, sorry, that's fine. Yes, so Ms. Maureen D. Knighton will join us via a video conference to make a statement. Thank you.
Project. The Doris Duke Foundation launched the African Health Initiative in 2007, and we pursue a more creative, equitable, and sustainable future through our support of arts and culture, nature, and health and well-being. The African Health Initiative was a transformative program aimed at strengthening health systems across sub-Saharan Africa, a novelty for the foundation at the time. The primary objectives of the African Health Initiative included strengthening health systems to deliver integrated and high-quality primary health care, supporting local ownership of solutions by empowering national and community leaders, promoting real-time learning systems to address health challenges effectively, and building capacity for implementation science and research to inform policy and practice. By fostering partnerships with local governments, academic institutions, and healthcare organizations, AHI has become a cornerstone in advancing health systems innovation and sustainability. The embedded implementation research approach is at the heart of the African Health Initiative's success. With this distinctive approach, research is conducted within the framework of health system strengthening initiatives. Instead of operating as a separate academic exercise, it's seamlessly integrated into implementation design and execution. It emphasizes partnerships among researchers, policymakers, practitioners, and community members to ensure that the research is not only relevant but also actionable, with findings directly informing decision-making. This integration helps align research priorities with real-world health challenges. Its combination of collaboration, real-time learning, and local ownership makes it a highly innovative and impactful strategy for strengthening health systems and improving health outcomes. This approach has emphasized supporting national and community leaders to take charge of health interventions, promoting research to refine health interventions and sustainability. DDF has provided almost $90 million in funding to the African Health Initiative, underscoring our commitment to strengthening health systems in sub-Saharan Africa. The foundation has invested in Ethiopia, Ghana, Mozambique, Rwanda, Tanzania, and Zambia. This investment has achieved measurable success in strengthening health systems and improving health outcomes, including reductions in under-5 mortality rates, improvements in immunization coverage, increases in fertility, increases in access to primary health care services, and utilization of maternal health services such as antenatal care attendants and skilled birth attendants, as well as uptake of data for decision making. Findings from AHI's implementation research have also informed national health policies and revisions of standard operating procedures. Further, the African Health Initiative has invested in training healthcare workers, researchers, and policymakers to strengthen the overall health system. The initiative has produced more than 350 publications, trained in excess of 3,000 researchers, decision makers, and health workers, and strengthened the institutional capacities of more than 300 health facilities and research institutions across the continent of Africa. The initiative has also fostered international collaborations linking African researchers and policymakers with global health leaders and academic institutions. Starting from phase 1 in Ghana, the African Health Initiative has made significant investments focusing on strengthening health systems in 3 rural districts in the Upper East region. In 2016, phase 2 funds were allocated to scale up interventions to the Northern and Volta regions. Successful models developed under these projects have been scaled up and replicated in other regions by partners such as COICA and USAID. The African Health Initiative exemplifies the power of partnerships and local ownership in driving sustainable health system improvements. Its focus on strengthening health systems and promoting learning has not only saved lives, but also laid the foundation for resilient healthcare systems in sub-Saharan Africa. We are deeply inspired by the impact of the initiative, and as a donor, we are not merely spectators in this journey. We are partners invested in the enduring impact of the African Health Initiative. And we're committed to promoting its sustainability. That is why the Foundation is supporting the establishment of a community of practice for the African Health Initiative. The Community of Practice, or COP, is a collaborative platform that brings together researchers, policymakers, healthcare practitioners, and other stakeholders to share knowledge, experiences, and best practices. This community fosters a culture of learning and innovation by enabling members to exchange insights on health system strengthening and implementation research. One of the key strengths of the AHI COP is its focus on capacity building and mentorship. By providing training opportunities and resources, the community of practice aims to build a critical mass of implementation science researchers and practitioners to drive evidence-based decision-making, contribute to the sustainability of health system improvements, and amplify the impact of the African Health Initiative by ensuring that lessons learned from AHI-supported projects are disseminated widely and applied effectively. As such, we are delighted that the Community of Practice is organizing this landmark conference to promote knowledge sharing and lessons learned from the development of context-specific approaches to health systems strengthening. The milestones we've collectively reached stand as a testament to what collaboration and shared purpose can achieve. I extend our heartfelt congratulations to the dedicated country teams. From the inception of the African Health Initiative, we at the Doris Duke Foundation have placed immense trust in your vision, commitment, and ability to drive meaningful change. Today, seeing the progress you've made and the lives you've positively impacted reaffirms our belief that this investment was not only justified, but also essential. Once again, we express our sincere pride and gratitude for the exceptional work you have done. Thank you so much, and we look forward to your having a successful and impactful conference.
We thank the representative of the Doris Duke Foundation. Ours is an attitude of gratitude. When you do meet her online, please tell her that. Professor Bauer is accompanying someone. I was thinking he would do the official launching of the conference. Before we take the Dr. Emisa's closing remarks, we need someone to pronounce that the conference is officially launched. So Professor Wandari would now officially launch the Health Systems Innovations Conference.
Okay, thank you. It's my honor and pleasure to formally declare this very timely and important conference on innovations for health system strengthening duly launched. I wish you a successful conference.
Thank you, Professor Wandari, who is standing in for the Vice Chancellor of the University of Ghana here at the Hill of Knowledge. We will now take the chairperson's closing remarks. So let's listen to Dr. Emisa, who is representing the Ghana Health Service Director General.
Thank you very much, Mr. MC. Thank you very much, is it a congregation? Is it we are in the university, an audience? This is not church. It can't be congregation. So thank you very much, my audience. And thank you very much. I think before I took my seat, I said that my DG had asked me to step into his role as the chair. So I had accepted that role. Maybe I may not have overtly or expressly said it, but I needed you to support me to do this chairing, and you have done that excellently. One of the things he said to me was, this thing wanted to start at 9, so I should make sure that I'm here by 9. And I know in Ghana when they say 9, it's 9:30 or 10, but because DG said it and he doesn't joke with his time, I decided to also follow suit. And truth to word, when I got here, all the dignitaries were there waiting. I didn't know. I was told we should be seated by 9. So I think I just walked in and sat here. The ladies wanted to move me out, and I said, no, I want to stay here because it's 9, and I think the program says we should start at 9. So indeed, we started just a little bit after the 9 that we were supposed to have started. I think 9:10, 9:15. But we have done very well. Can we clap for ourselves? We have done very well. We are even behind time. No, if I say behind time, it means we are late. We are ahead of time. We are really ahead of time. And to think that, yes, indeed, an equally important activity is happening in the ministry, I think it serves us all good. Dr. Awono, you saw him ask for permission to leave. I think he's joining the minister to launch the Mahama Care Trust. I will not repeat what has been said. I will attempt to summarize what has happened here this morning, being the chair. So we all started with a nice prayer, and then I was asked to give my opening remarks, which I did. Forgive me, at the time I gave the opening remarks, I didn't know who were in the room. So now I know that we have the rep of the VC, so let me address him properly, Dr. Awindara. Is that Awindari? Prof. Awindari, the rep of the VC, and I think he's the Pro-Vice, yes, Chancellor for, is it education or something? I heard, yes. Come again? Academic, yes. So then we have the Director of RIPS here, I want to address him. Then we have Dr. Felix Asante. I don't have the program. He is also a very big Pro-Vice Chancellor. Okay, yes. So we have very important and big personalities in the room. Forgive me, initially when we started, I wasn't even sure who was in the room. After the prayer, I was asked to come give my opening remarks, so I couldn't properly address them. So I'm acknowledging all the professors and directors and very important guests that we have in this room. And then we had a purpose of gathering and conference expectation from Professor Bawa. Obviously, he told us why we needed to collaborate. He made us understand that collaboration allows for pooling resources and expertise and innovations, just like we are doing here. So we have solutions in tackling our own health issues. Then also, he made us understand that some of these things, once we pull people together and we are doing this, it happens to be content-specific solutions. So we look at how we can pool resources together within our context, so we know how limited resources are in our terrain. And then it also helps us to take cognizance of our cultural practices. So the things that are important to us, we don't throw them away because an intervention or an innovation has come to us. We make sure that we have that at the back of our minds when we are planning or designing these interventions. And I believe that is what's happened with the CHIPS, and we know how and why it is the bedrock of our primary healthcare system now. So I think it's a very good point to also note. Then he also mentioned how these things also help us to build capacity and share knowledge. So it fosters knowledge sharing, and then also that is essential for our health service improvements. You cannot improve if you do not have knowledge on what is being done and how it's being done and the results and all that. So it also fosters that. So I'm very happy that he touched on that. Then Professor Felix Asante also came to let us understand and also know that the university is committed to strengthening its role in intensifying research and innovation, and I think that is also an important role. I know there are various academic departments or units that are interested in research or that promote research in various areas. So this is an academic university and we have various departments. I believe research is a good thing for academia because it helps us to get the evidence that we need to support whatever we are doing. So it shows us the results. Then again, it also helps us to monitor the things that we are doing. We can use research to evaluate programs. We do that. So I think he also made that known to us. Then, of course, Professor Windari came to welcome us because he knew the people in the room. He was able to welcome all of us, and I believe we all felt very welcomed. I did, because he could even mention my name and know that I'm representing the DG and all that. So he did a good job with that as well. Then we moved on to the keynote address from Professor Wono. He also gave us the history of various interventions that are happening in the country. So he mentioned how CHIPS started, how we went through the GAEP, it came to improve, and then we moved to CHIPS Plus, which we are still working on. He also talked about emergency systems, health systems, how research has helped us to improve the response in the emergency healthcare systems that we are operating. He also talked about electronic medical records. So we all know how we are moving to digitalization of a lot of things that we do. Now you go to a lot of places, your Ghana card is linked to so many things, your bank, even I'm sure the university as a student, you have to link your Ghana card to your student card or whatever it is. Digitalization and interoperability of these systems are very key and important, and we have seen progress with that in other places. So then we are learning and then we are doing the same, and it's facilitating a lot of things. Now when you are traveling within the country, you don't need your passport. If you leave your passport at home, it's no problem. You have your Ghana card and it's been inputted into the system, and at the airport, immigration is able to know who you are and have all your details. He also talked about telemedicine and how that is also helping to improve our healthcare system. So a doctor can sit in Kolebu as a specialist and be able to talk to his colleagues somewhere in the very rural areas where they don't have this expertise that is needed, but is able to link up and collaborate with that worker or that professional and be able to support the healthcare of the individuals in those areas. So all these things have been very progressive. He mentioned about the national health insurance. Yes, we started and there were a lot of challenges, but I believe that it's working well in some areas. It's really working well. I remember in mental health, just last year, we've been added onto the national health. If I say we, I'm just coming from mental health, so I'm still well embedded in what they do and I'm aware of what they do. So even though mental health services were free as a country, people ended up paying when they get to the point of use, because there was no system where we know that the funds will be coming to the facility, or they hadn't been arranged properly. So government will send funds, but when it sends funds, it's for a whole lot of things. It's not particularly for patient care. But we wanted where we would have, like how you have your insurance card and you can go for your hypertension and your diabetes, to be able to go for when you are depressed, go to the hospital for the doctor to take care of you without paying anything. And luckily, this health insurance, which we are practicing, and a whole lot of things are coming on board. I'm happy to say that 4 conditions for mental health have also come on board, and it's improving. So these things start gradually. I'm sure we have challenges. We do the researches, we understudy what we are doing, and then we improve on the system. So I think it's a very good area. Eventually, we got to understand that these partnerships that we are going to showcase, or that we are showcasing, helping people or intervening in various areas, under fives, mothers, whatever, they all go to improve the healthcare system. And not just that, it builds the capacity of the staff who are used to provide these interventions, and they can scale it up, and then the general health system improves. Finally, I also want to touch on the donor speech. I think our lady who is in charge of the African Health Initiative tells us how it is an initiative that supports health system strengthening. So she mentioned that it is an initiative that is looking at integrating health systems and then making sure that quality health care services are provided. So she also talked about how they foster partnerships with local governments, academic institutions, researchers, health workers, and then how they collaborate, and then in real time they learn to promote the health system of various countries or communities. So they do that also being mindful of the context in which they are working. She mentioned that as being very important, and that it promotes ownership. And I think we have also learned that from some of the interventions and when we are implementing them. She also mentioned how their support, they make sure that the health system strengthening leads to resilient health systems. So I remember when COVID came, we said that yes, we saw that our health system was not that resilient. It would have collapsed if we had the load of cases that other countries, the developed countries, were having. Luckily, ours wasn't that way, and then people were ascribing all sorts of things. I'm sure research could possibly go into that and say that yes, it is our weather, it is our resilience as a country, as a people, and all that. I'm sure we are yet to be able to say or attribute why maybe Ghanaians or Africa, the deaths were so low compared to that in the West, the Western world. So she mentioned all that, and I want to use this opportunity to thank the foundation very much for their commitment and their support. I think she said that they are still working with us. They are happy to continue the work they are doing because they are seeing results, and they are working in so many other countries, with Ghana included. And I think we are happy about that, and we are very grateful. Last but not the least, I want to thank our dancers. I enjoyed the interlude. I don't know about you. I think maybe it's been work, and very little time for recreation or winding down, especially during working hours like this, 10 o'clock. Who will you get to come and do a nice, is it a Volta region? Yes, it was Volta region. A nice dance like that for us. I enjoyed the sound, the drummers and everything. So I want to acknowledge them, and then ask that as much as possible, we should involve some of these things when we are doing our programs. I think it helps, and it's context specific for me. I think that's how I saw it, that we are mentioning context specific for health and everything. But for here to our conferences, this is context specific. That is what we do when we are relaxing in our hometowns, in our homes and villages and all that. So I saw it as very relevant. So in rounding up, I want to say a very big thank you to each and every one in this room, the organizers, our media friends here. I believe that the rest of the 2 days, we are going to be really committed, and we're all going to be here, listen to the presentations, learn. I think for me, the key word has been learning, promoting learning, building capacity, making sure that we build on what we already have, and then we learn from what others are also doing, and be able to scale up to improve. I think the ultimate is making sure that we have a good health system. Not just that, but we also have good health. So as individuals, I'm sure we'll hear a lot about maybe hypertension, the NCDs especially, which are cropping up in our healthcare system. So I believe, I expect that we will all be committed. Let's be here, let's learn, let's share, and then let's discuss, so that at the end of the day, we can take up these things and inform policy. I'm happy that some of our policy makers are in this room. We have our director, PPME here, his staff, other staff, and other research persons are here. I believe that we'll be able to pick up some of these things and be able to use that to inform what we do. So thank you very much, and I wish us a fruitful 2 days. Thank you.
We need a bigger round of applause for the chairman. Please show by hand if anyone is surprised that the Director General of Ghana Health Service designated Dr. ISSER to come and represent him. I hope that whoever is delivering the vote of thanks will remember that she acquitted herself creditably. Thank you very much, Dr. ISSER. It has come to my notice that Professor Ayamga of the University for Development Studies is here to join our conference. Professor Ayamga, you're welcome. We also have Dr. Dennis Chiraura of the School of Public Health at the University for Development Studies, who is also here. And he is my head of department. If I don't acknowledge him, he will assign me courses to teach. May I now call on Dr. Charlotte Ufori to kindly step here and deliver the vote of thanks.
Madam Chairperson, distinguished guests, esteemed organizers, respected speakers, and participants, please permit me to stand on existing protocols. On behalf of the entire Health System Innovation Conference organizing team and the Sustaining the African Health Initiative Community of Practice Secretariats, I am privileged to deliver the vote of thanks as we officially commence our conference. First and foremost, we express our deepest gratitude to the Almighty God for giving us this day and granting resources, knowledge, and strength for the organization of this conference. We are immensely grateful to the Doris Duke Foundation, whose unwavering support has been instrumental in nurturing and sustaining the African Health Initiative Community of Practice program and bringing together researchers, practitioners, and policymakers to exchange ideas and drive health system innovations. We are also thankful to the Regional Institute for Population Studies at the University of Ghana and the Ghana Health Service for their collaborative efforts in organizing this significant event. Their dedication to health systems innovation and commitment to fostering impactful change in Africa's healthcare landscapes are truly commendable. To our distinguished chairperson, we thank you for hosting and for participating in this program. We are also grateful to the host and the special guest of honor, the keynote speaker, and all speakers at the opening ceremony. We thank you for sharing your expertise and vision. The insights from your statements have given us food for thought for the discussions and collaborations that will take place during the conference and even beyond. Special recognition goes to the organizing team and committee whose tireless efforts behind the scenes have made this event possible. We are truly grateful for your hard work. Can we give them a round of applause? We also extend our heartfelt gratitude to the abstract reviewers whose expertise and meticulous evaluations have shaped the program we are about to experience. Your efforts ensure that the conference features high-quality presentations and discussions. Finally, we acknowledge the presence of all participants, policymakers, researchers, health practitioners, and early career scholars who have joined us here today. Your active engagement and contributions will be the cornerstone of this conference as we share innovations, foster cross-learning, collaborate to address the challenges facing health systems in Africa. Thank you all, and I wish you a fruitful and impactful conference.
All too soon, we are wrapping up this morning's program. Before I call on someone to deliver the closing prayer, let me just say that it was a privilege for me to be the MC, and if I've committed any infractions, please forgive me. If dignitaries are here that have not been singled out for special mention, please it's not deliberate. You are no less important than those who have been openly acknowledged. On this note, may I call on, who else but a Christian? Dr. Aaron Christian. So before that, let me just say that there would be a group photograph this way, and after that we'll go for a coffee break, which is just close by. Once they say the opening prayer, it means that my job is over. Thank you very much for your attention. And the closing prayer.
Thank you very much. I must say, my brother Sheikh, Professor Abu, was supposed to give the closing prayer, but he's not around. He asked me to do that. Shall we humbly be on our feet? In the silence for just 5 seconds, thank God for how everything has ended and wrapped up so beautifully. Eternal God, Most High, we are grateful. We know we couldn't have done and come this far without your strength. We commit the rest of the program and the conference into your hands, that it should be successful. We thank you so much for guiding us up to this point. In Jesus' name we pray with thanksgiving. Amen. Thank you all.
How do we really advance the health of women and children in developing countries?
This
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow-on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motokin ambulances. This is a local initiative.
With the introduction of the motokin to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
how do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80. porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a emergency public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first
Hello?
phase of the African Health Initiative, we
So in a few minutes, we would be reconvening here, and then we break out into our parallel sessions.
Process, we narrowed down and awarded grants to pilot
Group
projects
1 will be here in this conference room.
Ghana,
Group 2 would be in a room upstairs, seminar room 2, and then the third group would be at RIPS at the computer laboratory, the computer lab. Group 1 will be here, the first session will be here, the second one will be upstairs at seminar room 2, and the third one would be at RIPS at the computer lab. So in a few minutes, we should be breaking out into panel sessions. don't want to sort them out.
Should I sort them out for you?
Have you taken the copy for the set for the lady?
Yeah, I have.
You do it. Oh, then that's fine. That's okay. Thank you very much.
Benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital, e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals will solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system.
Hello?
We are focusing on community-based primary health
I hope everyone
system
has had
as the
something
basic
to
primary
drink and
healthcare
something to bite.
vehicle to drive system.
The parallel sessions are breaking out now. The Ghana Health Service will be in this room. Health Systems 1 would be upstairs in seminar room, room 2. And the Health Systems Research will be at the RIPS Computer Laboratory. If you have any issues, please contact me or any of the organizers. So if you break out into the sessions, we'll be pausing. We'll pause at 1 o'clock for lunch, and then we'll resume for the plenary discussions at 2 p.m. So it might be useful to try to maintain the consciousness of time that we have exhibited this morning and bring it to bear on how the discussions go at the parallel sessions. Thank you. Hello?
You can't ensure.
For the Ghana Health Service, who will be in this room, the moderators are Andrews Ayim of the Ghana Health Service and Samuel K. Boating, also of the Ghana Health Service. Presenters will be Michael Opoku Mreku of the Ghana Health Service, Nana Mreku Jima, also of the Ghana Health Service, Abdul Jalil Mumuni, and Michael Yao Amwakong. So this is the panel session that will be here. That's specifically for the Ghana Health Service innovations. The Ghana Health System Strengthening Panel would be in ISSER Seminar Room 2. That is on Ghana Health, the health system strengthening. And the moderator would be Dr. Pel Che of the University of Ghana. And we have Andrew Vance Bray, Farouk Ishaq Sa, Messi Ajay Adumata, and Atipo Welinam Aku would be presenting. Breakout session 3 would be at the RIPS Computer Lab, and it's on health systems research. The moderator is Dr. Adriana Baini, and then we have presenters would be Mehari Gebre Tekleji of the University of Adigrat in Ethiopia. It might be online. And then Francis Torreblanca, Idrissa Wedraogo, Leonard Kambewe Nafazi would be health systems research. They would be at the computer lab at RIPS. So far, we are not doing badly with time. I hope we can maintain the momentum. In a few minutes, we should be starting the sessions. Thank you.
Need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
Hello. Good morning. Good morning. We want to feel you. Good morning. Yeah, so we would like to begin our session for the sake of time. We have our 1.5 hours, so 1 hour, 20 minutes. I am Dr. Sambo Kwabnabu-Achibuatin, Director of Policy Plan Monitoring Evaluation Division of the Ghana Health Service, and my co-chair,
Dr. Andrew Sayim. I'm the head of policy for PPMED Ghana Health Service.
And as we heard this morning, we want to keep it brief. This is about health systems innovation. So today we'll be hearing from 4 experts in several areas. And we'll discuss from geospatial, home visits apps, and also from CHIPS, which we heard a lot about. So without much ado, we want to invite the speakers to the front. Yeah, so every presenter will have exactly 15 minutes, but you'll be prompted when you have 5 minutes to the time and 1 minute to the time. And please keep to your time. When it's 15 minutes, we will stop you and move on for management of time. The first presenter with that
any particular order. It's from the Ghana Health Service, Michael Opoku-Mriku. Let's welcome him from the club. Michael Opoku-Mriku, you're welcome. The Michael Opoku-Mriku will be talking on geospatial insights for equitable health care access, optimizing facility expansion and service utilization in Atebubu, Amanti municipality. Then next, let's welcome from the Ghana Health Service again, Nanam Mriku Jima with the club. Nanam Mriku Jima is a district director, a very good friend of mine from the Western region. I've met him at several conferences and senior managers meeting. She'll be talking on the home visit app for monitoring and supervision and evaluation of home visits and innovation towards achieving universal health coverage. You can continue. Yes, okay, so the next one is Abdul Jalal Mumuni of the Ghana Health Service. And you be, please, come in. Is Abdul Jalal Mumuni here? Okay. Then we have Michael Yao Amwakun of Ghana Health Service. Okay, good. So Michael will be talking on impact of LIMS on healthcare service delivery in Boku West District Hospital, Upper East Region of Ghana. So you are all welcome. Yeah, so interestingly, until recently I was in Boku West. These are some of staff of my district directors, and it's a happy reunion. I don't know whether the presentation is set for those who want to start with Michael Opoku-Mriku. Like I said, he's going to speak on geospatial insight for equitable healthcare access, optimizing facility expansion and service utilization in the Atebu Amanti municipality. Let's welcome him with the clap. Please just keep your questions. We'll take the 4 presentations, and after that, we have 20 minutes for questions. So you have the floor.
A very good morning to everyone. My name is Michael, and I'm the Chief Food Soldier for Atebubu Amanti, and I will be talking about the geospatial distribution of facilities and how we are using QGIS and tools like Access Mode to plan and make decisions in the Atebubu Amanti municipality. So we'll go through this outline, and by way of introduction, we understand that generally to be able to reach the universal health coverage that we look forward to, we would make up for the inequitable access to healthcare that most of us presume to exist. Sometimes getting the data to pinpoint the disparities is a little difficult. So we also understand that rural Ghana would usually have the challenge of this kind of disparities and inequitable distribution. As an example, by policy, we understand that for everyone is supposed to be within 5-kilometer radius of a health facility. So that in Atebubu Amanti, with a square kilometer of about 2,600, the expectation is that there should be about 33 facilities evenly distributed, assuming that there are people everywhere in the district, so that everyone is adequately covered by that principle. And the question is that if we don't have all the 33, or even if we have up to the 33 and beyond, is the distribution such that we would get that kind of coverage that is expected? So we want to look into that and then see what other make-up solutions exist and how by other parameters we are faring as far as access is concerned. So that's what this is really about, so that we'll be able to do proper planning and strengthen the health system at large. And that is what is driving this whole thing. So these are the objectives: to look at the geographical distribution of the facilities, to analyze the physical accessibility of the services using travel time. You know, that's another dimension of the analysis that usually doesn't come out too clearly. And then we'll also juxtapose that with the utilization patterns to be able to make sense of whether the travel time and then the physical availability is necessarily translating into utilization. So these are the things we'll do. So the methods, we use GHS to show the spatial distribution of the health facilities, and then also to show the population distribution. Sometimes there's a temptation to think that where there isn't a facility, especially in rural Ghana, maybe it's because it's a huge plantation or a huge farm, so there's nobody there, and then we are okay. But the population distribution would help us to see whether truly, where there are no facilities, are there people or it's a farm? You know, that kind of thing. And then we go ahead to use the access mode to build a model. What access mode does is that it looks at the terrain. It takes things like the road network, whether they are good or bad. It takes the slopes that may exist, you know, whether it's a hilly area, because if you are traveling a hilly area, you are likely to take more time than if you're traveling a flat planed area. So it takes into consideration the barriers like rivers, like lakes, like bad roads, all of those things into consideration, and then models how easy it would be from one point to get to a health facility. So we'll do that, and then also look at, that's what we call the geographic coverage. And then there is a population coverage, which gives us the proportion of people who have easy access to a health facility. And by easy access, we mean that given that a person gets motorized transport, how many people would have 30 minutes access to a health facility? That's what we call population coverage. So we'll look at that, and then finally, put facility utilization data on top of that to see whether the two are balancing or not balancing. So this is the first map of Atebubu-Amantin. It is what you see here. And the facility distribution is exactly as you see. The plots and the dots that you see in there. Oh, the light is not. All right. So for the sake of time, the facilities are as you see there. And there are a total of 21 health facilities in the municipality, and they serve 157,000 people. Already, I'm sure that is beginning to give you ideas. Like we said, they're expected to be about 33, but we have 21. And so we can begin to draw the picture in our minds. 14 of these facilities are CHIPS, maternity home, 3 health centers, 2 hospitals, one of them is private. So of the 21 facilities, 3 are privately owned, and 6 of the 21 are clustered in Atebubu. And you can see that in the middle there. What we did was to look for a 10-kilometer radius around the district so that we can get to know what facilities exist there. Because let's face it, if someone lives at the borders of the district, they are not necessarily going to come into the district to look for a facility if there is one close by in the adjoining district, because these barriers are just imaginary. And so you can see that there are facilities outside so that they provide proper context. And that is that. And so some of the facilities are clustered in one particular spot. But for the facility, we also provide the 5-kilometer radius around it to see the coverage. So that everywhere you don't see that radius around, it means that they don't meet the policy prescription that is required for them to be covered. But like I indicated earlier, the temptation might be to think that those places may be big farms. So we provide population distribution so that we see whether they are farms or not. And the many dots you see there represent population density. So if it's a dark dot like the ones you see around here, like these parts, these ones, it means that there are people there, but it is not a densely populated area. Where you see that it is brightly colored, like in the middle part here, it means that there are people there and it is densely populated. So that is Atebubu town, you see in the middle there, that has the golden color, sort of. And that place has the cluster of about 6 facilities. Then the other places all have population everywhere. Look at a place like the Kumfia sub-district. There are 6 sub-districts. The Kumfia sub-district, in the middle there somewhere, where the circle does not cover, there are people there and there is no facility. Look at Atebubu and Garadima, southern parts, there are no facilities there. So that is problematic if you think about it in terms of the policy prescription. All right. So we also, this is a production of the road network. And when you look at the first map here, I know it might look clustered or cluttered where you are seated, but I would try to make sense of it. It is all the entire road infrastructure in the district you see in the first one. And in the second one, what we did was to just take out the ones that are not tarred, so that you would get a picture of the roads that are supposed to be tarred. Not even that they are tarred, but they are supposed to be tarred. So all of these, and these are the tarred, supposed to be tarred ones. And you can tell that this one looks far clearer than this one is, telling you that majority of the road infrastructure we have are not tarred. But the ones that are tarred, the one that goes from down here up to the, yes, that go from down here up to the top, that one is the primary road, is the main highway that we had. It goes to Yeji. And the one that crisscrosses from left to right, this one, is a secondary road. And the other one that you see, the green one that you see on this side, is a tertiary road. They are all supposed to be tarred. Unfortunately, only the primary road is tarred with potholes. Nice ones, some of them manholes. And then the other ones are not tarred, even though they are supposed to be tarred. Now, notice again that the facilities, 18 of them are on these 3 roads. 18 of the 21 facilities are on these roads. And what it means is that the people living in various parts of the district must use the feeder roads that are untarred, from what we have shown so far, to access the facilities on the tarred roads. And the feeder roads are terrible. So that alone should tell you a picture of what is happening. So we used that information, the untarred roads, all of the mess that you kind of saw there, to draw this map. And this is showing what we call the geographic coverage. And looking at the map carefully, wherever you see a bright color, that means that within 15 minutes, anybody staying anywhere in that area would get access to a facility. Anywhere that you see the yellow, anybody staying there can get a facility. As the color gets darker, it means that the distance worsens, so it becomes more problematic to reach a facility. And so you can clearly see from the southern part of Garadima, the last sub-district here, that end there, that is close to hellfire. Because it's very dark, and people will struggle to come up. And remember that there are people there from the population distribution. There are people there. When you look at this other side of Kumfia, look at the Kumfia sub-district, you can see that chain-like looking area that is striped in there. Also, another close to hell area. And it is telling us how difficult it is for people to access facilities. Now, this population coverage is telling us what proportion have 30 minutes access to a facility. Garadima is the worst. There are 63.7% of the people there, within 30 minutes, they have a facility. But their OPD per capita, which is utilization of the facility, is 0.5. So if their coverage, easy access, is not so much, and their OPD coverage is not so much, it's understandable. Let's look at Atebu Boamantin, where the coverage is almost 100%, meaning that almost everyone within 30 minutes, they have access to a facility. And their OPD per capita is 1.3. The benchmark for OPD per capita is 1.2. So we are happy because it means that the facility is being utilized, access is easy, it makes a lot of sense. The problem is when you look at Jatozongo. Even though accessibility is relatively easy because 91% have access to a facility, the OPD per capita utilization is as low as 0.3. And that is not correlating with what we have seen of the other two. What it means is that they are not utilizing the facility not because of geographic problems, because geography is not a problem for them. If they are not utilizing it, then it is probably because of demand side issues. It is probably because they are not happy with the facility, the service quality. And so we understand that that must be the focus for Jatozongo. Similarly, when you look at Kumfia, you see that it's 87.7 access. But the OPD per capita is very low, 0.27. Why is it that they have easy access but are not utilizing the facility? It is not geography. it is simply because they either don't like the facility or the service quality, and so they are not utilizing it. Looking at understanding the context or the dynamics there, in Kumfia in particular, the problem might be the non-availability of transport. There are no easy means of transportation there. So even if you want to go, you can't go. That is a major problem. All right, so basically, we understand that there are major geographic and utilization disparities in the district. And so it might help to establish a new facility in Garadima, because despite their low level of coverage, they are still using the facility. And so if we give them a facility where there isn't a facility, that population will be covered and it will increase utilization. But for the other two, Jatozongo and Kumfia, our strategy will not be to set up new facilities, but will be to upgrade the facility, because the problem is that Jatozongo is quite big, but they have a CHIPS compound. An adjoining neighbor that is a smaller place has a health center that is doing much better. And we actually went there to interview the chiefs and the people, and the problem is that they expect to have a health center, because whenever they go there, according to them, they end up being referred. So they won't even bother coming to the chiefs. They just pick a vehicle and go to where they'll be referred to. And so that has become necessary for us to fix that challenge. Community engagement will also help to address the demand side problems with those particular two sub-districts. Finally, we are sure that geospatial insights would help us to be able to target our interventions, design our interventions properly, and target them properly, so that we would get optimized utilization of our services. And we are recommending that this is integrated into district-level decision-making, so that we'll be able to solve problems at our level that will not require complex assistance from anywhere. So thank you very much. Regards to Ghana Health Service, PPME for the support they gave us, WHO for the training on the access mode that they have given us over the years, and then my boss, Dr. Paulina Clara Pia, the immediate past regional director, for the direction that she gave for this week. Thank you.
Yes, thank you. You agree with me that it was very, very well delivered, and it had a lot of policy significance. And what I enjoyed most about it was the policy dilemma, or public health ethical dilemma that they presented, where sometimes we want to do efficiency, where plenty of people want to put facilities there. Because sometimes when we go and put it where there are no plenty people, then we think the cost of running the facility is high. So this work will help us to make some of those determinations. So thank you so much for this presentation. So please write your questions for him after all the presenters. So I would invite Dr. Nana Breku Jima to come and yes.
Thank you very much for the opportunity. I'm indeed honored. Permit me to present to you the home visit app for monitoring, supervision, and evaluation, an innovation towards achieving universal health coverage, the story of Mpohofiase. So this will be the outline of my presentation. As a way of definition, a home visit refers to a healthcare visit service where registered nurses or healthcare professionals who work within the community go directly to the homes of individuals or their families to provide various healthcare services and support. These visits are an important aspect of community-based healthcare, and where necessary, facility heads, the district health directorate, community health management committees, political traditional leaders, and/or opinion leaders are engaged to solve community health-related problems. Now, I brought this picture here to show you something in my district, my beloved district. This is one of the very first houses you'd meet when you get to my district. And what seems to be a pool of water. Okay, okay. So what seems to be a pool of water surrounding the base of the house is actually no water at all. If you look closer, the pointer doesn't show, but there's a very deeper brown aspect of the water very close to the house. This is actually wastewater from Galamsey activities behind this house. And the lighter shade of brown, or if you may have it green, that you see, is actually leaking fecal matter or effluents, as you may have it, from a leaking septic tank at a public toilet, also adjacent to this house. So you get the picture. With this kind of combination, you can imagine the plethora of diseases that the people inhabiting this house, the household, are exposed to. So, if you were a health worker and you were tasked with the duty of going to visit this home to offer healthcare services, will you go or not? To borrow from Shakespeare, to visit or not to visit. Now, I'll answer this dilemma for you because in the healthcare delivery module, a home visit in our context is mandatory and must be conducted in a professional and systematic manner. I think the essence of home visits is best exemplified with the Chinese barefoot doctors, where conducted in a professional and systematic manner. I think the essence exemplified with the peasant rice farmers to be able to deliver basic medical and surgical care to the rural folks they were living in their communities and actually in their homes. Fast forward, this initiative was so successful that, the height of improvement in population health and their coverages on their KPIs was so significant that it even influenced the declaration of the Alma Ata, which we all know that in the 1970s, all member countries of WHO decided that universal health coverage was incumbent on primary health care. To even buttress the importance of home visits and by extrapolation, primary health care, when the revolution halted the initiative, as significantly that the indicators improved, with the same measure, it significantly plummeted. So yes, if you come to our own context as a service, we know our NOP enshrines universal health coverage, and we want the vehicle to achieve this, we know, is primary health care. I think Dr. Awuno has already mentioned the importance of that with his CHIPS concept. So what do we do when we go for these home visits? We assess health status and needs of individuals and families within their homes and provide immediate intervention or refer where appropriate. We educate on nutrition, hygiene, disease prevention, and etc. We monitor the progress of individuals with chronic illnesses and those recovering from conditions, including wound care, vitals checking, and medication management, where we ensure individuals are taking the right medications at the right frequencies and doses, are compliant to the medications, and know and understand the potential side effects, and of course, what to do if such adverse reactions occur. We offer prenatal and postnatal care. We offer support and counseling to families with stress, psychological or emotional issues. We help clients to understand and access preventive health care, such as wellness clinics, vaccinations, and health screenings. We make sure we facilitate referrals where specialized care is required. Then we assess the safety of homes we visit especially for our vulnerable populations, including the elderly and disabled, to prevent accidents and promote a healthy living space. So they say necessity is the mother of all interventions. What brought up this idea of a home visit? During one of our DHMT meetings, we realized that, there's a manual reporting for home visits. It's actually a service provided by Ghana Health Service professionals, and there's a way of reporting it manually. Now, when we assess our manual reports, we see that we are beating our targets by far. We've done so many home visits, but it's not correlating with our KPIs. So if we have done so many for scheduled immunizations, if we have done so many home visits, why were we not getting our pregnant women to benefit from skilled delivery? Why were we recording higher rates of adolescent birth or adolescent pregnancies? They just didn't add up. So we decided to monitor, and that culminated in the home visit app, which seeks to assist health professionals in the digitalization of the home visit service provision. It helps us to gather comprehensive data to maximize the use of the home visit service and provides us with a platform for statistical analysis and operational research. So the application is a simple Kobo Collect tool where health workers download and take to the field. They download on their phones, go on field, and with the app, they're able to download data, whether offline or online. When this data is synced, it moves and is received by somebody we call the owner, usually a health information officer or anybody who is savvy in IT. And this owner analyzes the data for us to be able to know whether work was actually being done and what work was exactly being done. Furthermore, we've linked the form to what we call the Microsoft Power Business Intelligence software, which is a visualization and analytics platform that provides optics of the data as it is being populated on the field. Hello? Okay, so the form captures the credentials of the healthcare provider as well as the client. Then it will capture the various locations that the healthcare provider has visited to conduct home visits. And the app has a mandatory field that captures GPS location by longitudes and latitudes. And with these coordinates, we're able to tell if a healthcare worker actually went into the community and where exactly they went. All services provided by the health worker are also captured by the app. So this is the interface, how the app looks like. When you open the app, you will see it will capture the name of the staff, the category, whether it's a community health nurse, an enrolled nurse, midwife. Other, you state the dates the home visit is being conducted is also indicated. Then you indicate the sub-district, the home visit is being conducted, and then the community in which it is being done. Then you go ahead. So you go ahead to take the house address and any landmark that may help in the identification of the location. And then we record real-time location in latitudes and longitudes. Then you go ahead for the client, you take the demographics, the name, the age, the sex. You indicate whether it's a newly visited client or an old one, in which case you are revisiting the client. Whether you walked, used a motorbike or car to visit the client, and then you list in detail all services provided to the client. Where different services were provided for different individuals in the same household, we document all accordingly. Now, this is how the visuals look like after the form has been sent. So you see the brown circles you are seeing there. It's actually a healthcare worker moving from one house to another. and we are able to tell remotely from the directorate that this one is working here. We're able to know what exact services are being offered, which community is being offered in, and so on. So after development of the app, we piloted it in 3 facilities, 2 of our model health centers, and 1 CHIPS compound, which is the biggest CHIPS compound in the district. And our post-pilot findings were amazing. We increased by more than a 2-fold across all piloting facilities for the number of home visits. Our family planning coverage increased in both model health centers. In the CHIPS compound, it increased about 3-folds. Penta 3 coverage increased, our ANC coverage increased, and then our anemia at 36 weeks as compared to registration across all piloting districts was seen to improve when the program was piloted as compared to when we had not piloted it. Okay, so we attributed the increase in number of home visits to the fact that now healthcare workers knew they were being monitored. They were conscious that we were watching them on the log. So they were actually conducting their home visits instead of sitting in the comfort of their home and recording home visits. Then we realized that our Penta 3 doses also, coverage also went appreciated, because when we went for the home visits through the app, we were able to identify our first dose defaulters and follow up to give them the subsequent doses. Where we were unable to give it to them in their homes, we made sure they were referred to the nearest facilities to do same. When you look at the anemia in pregnancy, you will see that in 2023, when it was not piloted, for the CHIPS compound, even those at 36 weeks, 11 were more than those at registration, even though we reduced the numbers at the 2 model health centers, which Adumbansu reduced from 22 to 3, and Mansu reduced from 19 to 10, but the CHIPS went from 8 to 11. But in 2024, when we piloted, you see that across board, they all came down. We had 22 from 52.5, but if you look at the figures, they are still quite high. We thought there was room for improvement. So we developed what we call the HB Tracker Strategy 2, where we followed pregnant women from registration through 22 weeks and to 36 weeks. We monitored their hemoglobin level, their BMI, and instituted interventions such as iron folate supplementation, nutritional advice, and we initiated prompt referrals where necessary. After this, in a stakeholders engagement with Africa Leaders Malaria Alliance and Family Health Department of GHS last year, the district successes were, with improvement in anemia in pregnancy, were indeed noted on the RAMCA and nutrition scorecard. Based on this, we developed a proposal for funding entitled it Reducing Anemia in Pregnancy in Mpoho District through the utilization of RAMCA and nutrition scorecard management tools and hemoglobin tracker intervention strategy. We are yet to receive a favorable response for this appeal for funding. So to all the good people out there, reach out to us. Now, there were other findings that weren't so great, and this goes to show that the app is not a panacea for all problems in the district. Whilst it will solve some problems, it will give you room, the opportunity to identify the gaps in persisting problems. So you will realize that teenage pregnancy, although when stagnated at Manso Health Center, but increased in the other facilities. Skilled delivery also didn't do so well, and BCG coverage was not as we expected. Even though we increased in 2 of the facilities, we saw a plummeting in the other one. So what did we do? For the teenage pregnancy, we revamped our adolescent-friendly corners, which we realized were inactive. We created adolescent clubs in the domiciliary secondary school and 1 out of school. in the communities. And then we sought to conduct operational research to assess the prevalence of adolescent pregnancy and the unique socioeconomic and cultural predictors that were affecting adolescent pregnancy in the district. For skill delivery, we conducted refresher trainings for all our midwives. We lobbied for resources and supplied to some of our facilities. And then we lobbied for a theater, as our district hospital at the time had no theater. Okay, so that was the launching of the theater, and that is the theater. We were not without challenges. Staff attrition was a problem. Too poor staff could not buy phones, so they couldn't download the app. Too rich staff who had sophisticated phones like iPhone also could not download because the app powers only Androids. We lacked financial support to roll out a piloted program to all the districts. This is pictures showing some of our staff using the app, home visit app during their home visits. And then during our last annual review, we appreciated staff who used the app to encourage others to use it. Thank you very much for the audience.
Thank you very much. That was very good, Dr. Mreku. Like we've always said, when you inspect what you expect, or you look very intensely, you see more. And I think as a district director, it's been a district director, when we used to be district directors, it was the most powerful position in the whole Ghana Health Service. Because most of us at the top don't have any constituency, but you have a district and you can do as much as you want to do in it. And I think that is something that you've exhibited so well, and we really appreciate it. So another round of applause for him. Okay. So now, yes, we are lucky Abdul Jalil Mouni has come. So immediately we would invite you to the top so that you come and tell us about beyond service outputs, evaluating the operational efficiency of CHIPS in the Savannah region. So you have 15 minutes to do that. Thank you.
I believe it's still morning, so good morning, distinguished colleagues and fellow presenters. My name is Abdul Jalil Mumuni from Northeast Gonja District Health Directorate, Ghana Health Service, Savannah region. I'm honored to present our research on beyond service output. Beyond service output, evaluating CHIPS efficiency in the Savannah region using data envelopment analysis. I think my slide is not ready, so.
The slide is not moving. So let's go to the next place.
All right.
Yeah, sorry about that. So for the sake of time, like my co-chair said, we go the fourth. I'm happy to invite the fourth presenter. You know, I was in Upper region, and Boku West was one of my best districts. And I have this young gentleman coming to do a presentation. He is Michael Yao Amakon, coming to do a presentation on impact of light waves health information management systems on healthcare service delivery in the Boku West District Hospital, Upper District of Ghana. Let's welcome my mentee. Let's welcome the club. You have 15 minutes.
Thank you very much, Dr. Samuel K. Buache-Boateng. That's my mentor and my former regional health director. So my name is Michael Yao Amuakon. I'm presenting on the topic, the impact of LIMS on health service care delivery in the Boko West District Health Directorate. I also acknowledge my co-authors. They are not here with me. So this is my outline, my presentation outline. So when we talk about health record or record is the future. Record is the pillar and also a piece of memorization. In health system, patient records are vital. They are the legal information that we must protect. And the importance about patient record is that we one day use it for future medical references for subsequent treatment. Years ago, Ghana used to deal with a hard copy way of keeping records. There are times that you go to the health facility, you go to the health information system, they are looking for your folder. It will take like 30 minutes. We can't find your folder. Sometimes they'll bring the folder and, excuse me for my words, we have. The folder cannot be found. Some are torn, there are data missing. So in 2010, the Ministry of Health adopted the National e-Health Strategy, which was to pave way for the electronic health record system in 2013. And finally, in 2017, we had a breakthrough with the introduction of LIMS for keeping patient record. The purpose of the LIMS was to ensure easy retrieval and accessibility to patient health record, and also to overcome the burden which was associated with the hard copy record system keeping. However, we are still facing challenges with the LIMS implementation, such as the user adoption, the interoperability, the infrastructure remains. The purpose of this study was to assess the utilization of LIMS on healthcare service delivery, and also to identify the challenges which are associated with the utilization of LIMS in the Boko West District Health Directory, Boko West District Hospital. So the study was a descriptive cross-sectional study which was conducted in the Boko West District Hospital. The hospital, though is small, but serves as a referral for almost 4 districts in the Upper East region. The hospital is having a staff strength of 200, clinical staff strength of 267. The sample size for the study was determined using the Yamin formula with 10% non-response rate, giving us the 176 participants. With the convenient sampling technique, we enrolled the 178 participants. We used a structured questionnaire, and the SPSS version 27 was used to analyze our data. So please, let's look at our findings. Though the health field, especially the nursing field, is female-dominated, but the study found that most of the participants were males. Ideally, maybe it might be because of this recent migration to the European countries to look for greener pastures. We also realized that most of the health workers were having less than 5 years working experience. However, their computing skills was weak. They were beginners in terms of computer, in terms of operating with electronic health system. But this did not affect their LIMS utilization. They had challenge operating with electronic device, yet they had no option than to use the LIMS in service delivery. But we found that a significant proportion of almost 30% could not use the LIMS in their service delivery effectively because they had not been trained. We are now looking at our utilization and the challenges that the study found. We realized that almost 47% of the participants had not received LIMS training. Then we also found that LIMS, though, was effective in taking patient record, but there was a huge challenge to the utilization of LIMS in service delivery, which was the network connectivity. There are times that you get to the OPD, and the OPD is choked with huge number of patients because the prescribers could not access the LIMS. There are times you go to the ward and workflow is not effective because LIMS is not working well. We also realize that when the limited IT personnel was also a huge challenge. The hospital is having only one IT personnel who is supported by 2 national service personnel. So there are times that you will need the service of this IT personnel and the person is working with maybe a prescriber. So you cannot access him until he is done. So that was another huge challenge that the health workers in the hospital were facing. Another challenge was the lack of ICT infrastructures. There are some of the computers that are not working. Some of the tablets that were given to them, they are not working. Some are spoiled. And also the updates of the LIMS itself was a challenge at the facility. So we ran some few bivariate analysis to determine the factors that influence the utilization of LIMS in the facility. And we realized that computing skills. Most of the mothers were BBC. They could operate well with their phones. They could go to TikTok. But when it comes to LIMS, they had challenge operating with LIMS. We didn't know why. Maybe during their time when they were on campus, health record system was not introduced. But this was a very huge challenge to them. Okay, so knowledge on LIMS, the interface itself. There are times that you receive a call from a health worker and you come and say, where should I put the temperature? Where should I put this? So their knowledge also influenced their utilization. And this was very, very critical. This was serious. Because there are times that somebody will walk all the way from case wards. He is going to May ward for them to teach him or her how to use the LIMS well. We also found that inadequate training was also a significant factor influencing LIMS at the healthcare facility. So we come to our conclusion, our first recommendation. Though their competing skills was low, but they had no option than to use the LIMS. It's just like you sitting your dean's IA. You have no option, you have to write it. Because that's the only option that they can keep patient record. So we recommend that the Ministry of Health, through the Ghana Health Service and the Regional Health Directorate, should organize, maybe if possible, biannual training on LIMS or quarterly training on LIMS for our healthcare workers. And if possible, we should integrate electronic health record courses at the tertiary institutions. Because apart from health informatics, I don't think there's any specialized course that takes students through the electronic health record system. Because this is our future. When you come to the field, this is what we are using now. We are no longer dealing with the paper-based mode of taking patient record, but we are dealing with how we can keep patient record for subsequent medical treatment, for medical reference, also for future medical research. Also, the training, as we spoke of, is very, very needed. Then resource allocation and digital literacy. So Upper East is mostly rural-dominated communities. So sometimes we lack these resources. When there's allocation of resources, we prefer if the Ghana Health Service will ensure equity, so that those are the rural communities will also get access to these resources. Because there are times that I know that the resources will come, maybe 100 laptops or 50, but they will all stay within the southern zone. So if possible, when they are allocating resources, they could consider we are the upper there. Yes, LIMS improved patient care, but it's also faced IT, cost and network challenges, especially network challenges. So I don't know, maybe if we have some of the telecommunication networks here, or maybe to my director, if they can liaise with some of the telecommunication networks to provide us some of the best services to ensure that the interoperability and utilization of LIMS will be effective at the facility. Sustaining infrastructure is key for the future. We have to ensure that the limited resources that we have to operate with LIMS, we keep it well. We also have to ensure that we put down measures to ensure we sustain the electronic health record system for the future. And one more recommendation is that this study, though may not contain a lot, but it paved way for a subsequent study that we might need funding, which is to assess the state of the operability of electronic health record system in the Upper East region. So if maybe there's a resource funding allocation, they can consider we at the Upper East region too. Thank you very much. This is my presentation.
Please give a special thanks because he has saved us a lot of time. Yes, a good time. Yes, so I think, again, your presentation was great. It gives us, again, like you said, the policy dilemmas of equity and efficiency. Do we send more things, or for that matter, the telecom industries? Do they build more masts at places where they don't get business, but there's a lot of health that should be done? Or should they continue to build their profit masts at places where there are more people to buy their products? So these are arguments that we'll use some of these your findings to go and manage that policy discussion in that dilemma. And I think that is a very great one. And the other thing you said, which was also very great, was that academia should start pre-service training before people get there, so that hopefully by the time you get there, you know a lot more about a lot of things than to go and start. So I think this is a wonderful thing, and thanks so much. So I think we've been able to fix the presentation of beyond service outputs, evaluating the operational efficiency of CHIPS in the Savannah region of Ghana by Abdul Jalil Mumuni. So please come up.
Hello once again. My greetings and already observed protocol stance. So I'll just go straight to the point. Okay. So the format of my presentation will take the introduction. Let me just introduce that. We'll take from introduction, objectives of the study, methods and data, findings or expected findings, I should say, and then conclusions and recommendations. So, CHIPS, which is the community-based health planning and services, has been Ghana's flagship model for primary health delivery, particularly for rural underserved populations for decades. Traditionally, these CHIPS zones, performance assessment, heavily relies on indicators such as antenatal care visits, immunization rates, family planning acceptance rates, and home visits, among others. However, these matrices alone provides limited insights into how available resources at these CHIPS facilities are utilized to achieve targets or service delivery targets. Increasing need for resources because of dwindling resources makes it essential to empirically evaluate the operational efficiency of CHIPS to inform resource allocation. And so, on this background, we set out to achieve 3 key objectives of this study. The first one is to compute efficiency scores of these CHIPS zones based on the relative use of resources that they have at their disposal, that's inputs and outputs that they would produce using that. The second objective is to identify high-performing CHIPS zones that are on the efficiency frontier. The third objective is to explore geographical and structural patterns that may explain the difference in efficiencies that we'll be observing from the study. We used a cross-sectional analytical study looking at data from DIMS for 2024, and also some data from CHIPS databases from all the districts. We employed an input-oriented data envelopment analysis with particular emphasis on the model variable return to scale, which allows for variation in inputs from each of the decision-making units, that's the CHIPS zones. By that, we looked at inputs regarding health staff, so the number and mix available at each decision-making unit, that's the CHIPS zones, equipment available at the CHIPS based on functionality and number, drugs and other supplies, outreach points available to these CHIPS for service delivery, and then recurrent expenditure for providing outreach services at these CHIPS zones. The outputs we also considered to measure in terms of efficiency. We're looking at outpatient visits, ANC 4+ visits, supervised delivery, family planning, and fully immunized children, and we are considering Penta-3 and measles 2 in this case as the indicators of choice. Now, in terms of analysis, because we're still collating data, we have abstracted data from DIMS regarding these indicators of service delivery that we expect. We've also looked at a template to collate recurrent expenditure from each of the CHIPS zones regarding expenditure that was used for specifically outreach and home visit services. And by that, we expect that our analysis plan would compute the technical efficiency scores of these CHIPS zones as mentioned in the objectives using DAR from package in R. So we'll be using R for this data analysis in terms of computation of the CHIPS technical efficiencies. Then we would also be visualizing these efficiencies using plots of the efficiency scores that will show us the efficiency frontier at which the efficient CHIPS are operating. And then we would also be running a post-analysis to tell us the distribution in terms of spatial distribution of the efficient CHIPS within the region, and of course, the patterns of these efficiencies that we'll be observing in each district using ArcGIS Pro. Now, expected findings or results. We anticipate that there will be high variation or considerable variation in efficiency scores across the CHIPS zones that will be in the study. We also anticipate that resource constraints, such as understaffing or staffing constraints, what's the name? Inconsistent supply chains, the nature of the CHIPS itself, whether it's a CHIPS with a functional CHIPS with compound or not, the location of the CHIPS, we are hypothesizing that this may also underlie some of the inefficiencies that we may observe, and we would like to do that using our post-analysis estimates to find out if these have some underlying relationship with the inefficiencies we observe. And of course, we also anticipate that few zones are likely to be operating at the efficiency frontier in terms of findings. So our conclusion is that based on the expected findings, we want to conclude that the DEA approach can provide a rigorous assessment of CHIPS operational efficiency in terms of measuring performance of CHIPS service output, other than the traditional methods of measurement of service delivery outputs, mostly in the form of the holistic assessments that we've been undertaking every half year and then annually. We also want to conclude that this approach can complement existing service delivery output monitoring, like I've just mentioned. And then, of course, it will inform strategic resource allocation, benchmarking, and peer learning across these CHIPS zones in Ghana's primary healthcare system. Based on that, we also would recommend this approach as a diagnostic tool for identifying hidden underperformance in CHIPS service delivery. We also want to practically recommend it as a way of benchmarking for peer learning among CHIPS zones within the region and beyond. Of course, we also recommend that it can be used as a tool for strategic resource allocation and government reforms in that order. Thank you for your attention.
Yes, thank you so much. So I think I would invite Director PPMED, Dr. Boachi Burton, up. Thank you so much. You've saved us some more time. So we have at least 25 minutes to ask and answer questions.
Okay, so I think like Ayim said, we want this part, we have time, it was 20, 30 minutes. So we listen to these experts. In fact, I was happy listening to you. When I was your age, maybe I couldn't do the things you were doing. You were special and all those things. And that's great. So it's time for questions. We ask questions to encourage them to bring out issues. Because where we sit with my Deputy Director Policy, we are thinking through, do we adopt, let's say, this app for Ghana? So these are the issues. So we asked the first row with two, the second two, the third two. Then after we finished answering, we will look at our time. So Andy, take that back.
So let's start from here. At least the first two in this row to ask questions. If you had any questions.
Is there a mic you can pass around?
Yes, that's it. Okay, then we come to the middle. Oh, okay, there's somebody here.
Hello.
Okay. Oh, yeah.
Okay. Big congratulations to all the presenters so far. What I wanted to ask is about the home visit app. I wanted to see whether, as it's deployed, whether it is linked to an email or how you are able to view it whilst they use it. And also possibility of decentralizing it, or if others they are interested, whether there is the opportunity to adopt it at every place or selected locations. Thank you.
Yes, okay, the second one.
Okay, so thank you so much. And I'm Ankwa Sylvester. For the first presenter, in fact, your presentation was very good with regards to the geographical access with CHIPS. I was looking at, whilst you were talking about the universal health coverage, you see, with the universal health coverage, we are also looking at people are having access to quality services without financial hardship. And Ghana's achievement of the universal health coverage policy hangs on two components, namely the CHIPS, which is helping with the geographical access, and then the NHIS, helping to reduce the financial barriers. And as we already know, in the rural areas, there are a lot of people...
Please be a little snappy about your question.
Okay.
So that we can...
Actually, I was informing so that you could expand the research to look at how you can integrate the NHIS services into the CHIPS operation, so that that aspect will come and then reduce the financial barrier out-of-pocket payments of most of the rural people in the community.
Okay, wonderful. So that's a recommendation to you to add NHIS so that you can even look at the distribution of how NHIS is happening in the particular district. Thanks so much. So we would ask, is coming.
Thank you so much. They presented this very well, and I should applaud them. My question is this: what the Kobo collect for the chips, the home visit? I want to find out what is the frequency at which the data is downloaded. How many times do you want to go to a particular place? And then the GPS code, is it automatically generated or they have to input? And if they have to input, can somebody write them down and then sit out somewhere and input those GPS in his own bedroom, and it will appear as if the person has actually gone to the field? I think that's my question.
Thank you so much. So we'll go to the middle before. So please write the questions that are attributable to you. So the middle lane. Okay, luckily. Oh, okay. That's okay. The two.
Thank you very much. Thank the presenters. My question will go to...
Introduce yourself. So that
my name is George Asaritebi. I'm from Bono Region, the Health Information Officer. I will talk about the LIMS, and I'm happy the issue about LIMS have come up here, the challenges so far. I think the challenge is not only about utilization, but how the LIMS data is sometimes being distorted in some of the indicators. So it's very difficult to do reporting into the DIMS. For example, when you look at the malaria indicators, sometimes you see that malaria suspected is lesser than the one which is tested. You see a huge number of tested but suspected very small. But in the analysis of data in malaria, we look at you suspect before you test. But here is the case, the LIMS is actually doing the other way around. I want to know from the presenter whether his research was able to identify that. And also, PPME directors, you are here. I want to know the challenges, how far you've gone with it in terms of speaking to the developers, to actually listen to the users, to actually fix bugs and challenges and problems that are reported, because there's a common platform that they have to report all these issues, but sometimes they find it difficult to understand what is going on and even fixing the bugs that are actually occurring in the... however, the software is very good, and we have to work hard to make it work for us as a country. Thank you.
Thank you so much. Okay.
Thank you very much. My name is Emily Amponsa from Ekrapim South Municipal Health Directorate, the Health Director, the Eastern Region. I would like to congratulate the presenters. They did a very good job. My question goes to the PPME. The
presenters, or?
No, the presenters and
those of us moderating.
Yes.
Okay.
Yes.
Okay.
The LIMS. In my municipality, the choosing of the facility, we had issue with it, and now we are struggling with getting the NHIS data and then sending them. We called a couple of times and we didn't get any feedback. And also the internet, that connectivity that was placed there, we also having issues with it. Okay. And then I would want to, the first presenter, we want to find out whether they also looked at the public health activities, aside the OPD per capita, the facilities, because I know Garadima area and then the challenges with network and transportation. So if you are looking at only the facilities, what of the outreach services for public health activities? So if they did not, probably they have to look at it again. Thank you very much.
So thank you. So I think for choosing to be moderators, we've also had questions, but I hope the next person is not going to ask the moderators. Okay. So we are moving to this side.
Okay. Thank you so much. I'm Eunice Tangwam from Kasnana and Kana Municipal, the Upper East Region. I think our presenters did very well. Kudos to you all. My question goes to Dr. Mreku, if I'm not wrong, about the home visit app. I don't know whether, if I didn't notice, whether if there was a portion for routine home visits and special home visits. But then there's a portion I saw, first first visit and I think maybe subsequent visits. So I don't know, maybe I'll need clarity on that. Yes, but I think quickly, let me also add that with home visits, it's important to have, specify whether the visit is routine or special, so that at the end of the day, we would be able to tackle what exactly we seek to achieve. And especially when it's also special, at the end of the day, you are able to also identify certain key conditions that you need to look at.
Thank you.
And it will help a lot.
So thank you so much. Yes, so the next, yes, on the line.
Okay, thank you very much, and congratulations to all the presenters for the very good work being done in your various areas. Mine goes to the Mpoho district on the home visits, and I think some of the things I want to talk about has already been mentioned here, but I'll just stress on it. You know, CHIPS came up with a policy which is driven by the policy document, and to undertake CHIPS, you need some resources to go there, funds, the home visiting bags, and also the package of services to be delivered. And as mentioned by my sister here, the special home visit. So how were you able to provide funds for the officers to go to the field? And do you also have the home visiting bags and the package of services that they are supposed to deliver? Because I want to make sure it's really home visits and not home contacts. People can get to the homes, but the package of services to be delivered may not have been delivered. So if you are just monitoring the spatial information with the travels, you want to look at the contents of the visit. So if you can throw a bit more light on that, I'll be pleased with it.
Thank you
very
so much. Okay, so, okay, just pick a last one here, and then we can go back to the other.
Okay, good afternoon.
Yes.
My name is Tamimu Yakubu. I'm a lecturer at Tamil Technical University.
Okay.
So I just have one each for about 3 of the presenters, one each question for them.
Okay, be snappy with the one
okay.
each. Okay.
So the first presenter on the geospatial, presentation, I wanted to ask, but pardon me if I got it wrong. Your geospatial, manipulation of the facilities in the communities, were they just for CHIPS or they were for other facilities, whether secondary hospitals, teaching hospitals, or regional hospitals? I want to know that, so that when we have a particular community who have seemingly some number of facilities within them, but they do not patronize it, is it because those facilities around them do not render such services that they will need? For instance, if there's a CHIPS compound, they may not need those services, and so they may rather go to district hospitals or regional hospitals. Is it possible that was the case? And then for my brother from Savannah, I want you to just summarize. It's like, I don't know, I lost you somewhere with the findings.
What is the question you wanted to ask? Or you've not got the findings?
I want you to just summarize with the findings.
Okay.
I
so you're asking
really
him
get
to
it.
Summarize the findings?
Yes, exactly.
Okay,
and
so that's the question.
To my brother at Northeast, I want to know, because I worked in the hospital, at the teaching hospital for about a decade before I left to the academia.
Okay.
And so were those they pioneered the LIMS with. I was also part of them. But what I realized was that I could use my ID and actually comb around all the wards. I could practically see what every doctor was doing. Is it now tightened so that we are now saying everyone should go into the lane? Is it now tightened? Because when I was there, it wasn't really tightened, and there were issues with privacy. Thank you very much.
Thank you very much. So now we come to the answers, the responses. So I think we will start in that same order like we started, so that the first presenter will answer the questions ascribed to him, then the second, and the third, and the fourth.
All right, thank you very much. So the first one about integrating health insurance so that we would be able to check for financial access, that was not done. And I think that it can be done. The analysis has been done, multidimensional poverty analysis has been done, GHS in the district. Yeah, we can overlay that and see how it plays out. So that's a very good idea. Thank you for the suggestion. The second one is about the outreaches, whether outreaches were included in the analysis. And so here the interest was in the facilities that are available, their distribution, and then the utilization. And so we used, because it's facility, i.e. fixed places, we used OPD per capita as the standard. We couldn't have used outreach because by the health insurance stipulation, we can't include outreaches to our OPDs. But we have done similar analysis for outreaches, and that one would always be specific. So when we take EPI, for example, we have done that analysis, and we did it when we wanted to look at zero dose. We wanted to find the places which were at high risk of zero dose children. We did that kind of analysis, and we were able to pinpoint where it was likely, we were likely to find zero dose children. So we have also done for maternal health. Then the third one is about whether the facilities were all CHIPS or others. Yes, so we included all the facilities. There were 2 hospitals, 14 CHIPS compounds, 3 health centers, 1 clinic, and 1 maternity home. The point is that because they are, the CHIPS compounds are supposed to provide the basic package of services that are required, it is OPD services we are using, we are benchmarking with, or we are comparing with. And the OPD services, that is where you go to. If you have to go to a higher level, it must be the CHIPS compound that refers you. So the mere fact that they are not going there, they may be going elsewhere, even tells us that there's a problem, because then the gatekeeper system is still not working. So it is still problematic, whichever way you look at it.
Thank you.
Thank you very much.
Thank you very much. So the next.
Thank you very much. The first was, how is it viewed? Is it through email? And I think you were talking about the visuals, the optics. So the form, as I said, when it is synced or submitted, it is received by somebody we call the receiver, who can be a health information officer or anybody who is savvy in IT. And this person will analyze the data, okay, for us to know what work is being done. And so you actually see this because it is linked to the Power BI software. And I told you the Power BI software is a visualization and analytics platform. So once you have, the form is taken on the field, it is synced, received by the health information officer. It is powered by the Power BI. Then another, the second image I showed you with the round circles there, comes up showing you how the health worker is moving. Then the second is, can it be decentralized to be used at every place? So actually my appeal for help is towards this, because we were only as rich to be able to do this in only 3 of our facilities. We have 26. So if we're able to even show good practice, and then we're able to expand to our district, probably other districts and even other regions may fall on it. And frequency with which the data is generated. So we want, once the healthcare worker is on the field, we want it to be mandatory. Because we said home visit is mandatory. So once, as part of the home visit, we want you to make it a part of the home visit. Once you go out, you log on to the system so that we'll be able to monitor you for all the good reasons. And then you asked GPS, how is it inputted? Can you stay at home and then input the GPS? So you see, it takes real-time coordinates by longitudes and latitudes at the point of contact with the client. So indeed, if you stayed at home and you recorded the GPS for us, we will know it was your house, because the longitude and the location by specific coordinates of your house will come. And it will show on the map. You see, it has a background map showing the names of the communities, the topography, and all. So, yeah, so if you remember, during COVID, we would go for monitoring. We capture GPS where we are in real time. It's just like that. Then Sister Pat said routine home visits or specialized home visits. It's true. You see, we piloted this app, so it is still under construction. In fact, at our last annual review, we talked about this, and this question came up. We thought about either specifying which category it belonged to in the list of services, or there was also the option of the developer including a question with routine or specified for it to be ticked. So thank you and well noted. Yeah, then Dr. Frey said asked whether we have the necessary tools to work. Boss, we cannot brag to be completely ideal, but we've been conducting home visits since when, and we don't have the full package of items that are necessary to meet optimal community demand. But we do with what we have and try to advocate for more to come. I'll be a liar if we said we are providing full package work, but we are also not doing just home contact, because we try and do the best we can. I hope I answered.
Thank you so much. Okay, so the next.
Yes, thank you very much. I think my brother wanted to know a summary of my results and findings. Exactly, because it's still a work in progress. We won't be able to give you findings, but there are anticipated findings that we are actually looking at. And one of them is that we anticipate that there will be a considerable variation in efficiency scores across the 137 chips that we will be working with. We also anticipate that from the preliminary data that we've been collecting, looking at the 137 chips that we will be working with, we also anticipate that from the preliminary, looking at this, anticipate that very few chip zones would operate at the efficiency level that we expect. And then we are also hypothesizing that, or anticipating that the patterns regarding the location of the chips, the nature of it, is it a chips with a compound or not, where it's located, is it rural or peri-urban or urban, as against also the staff mix, can also give us underlying reasons why we are experiencing inefficiencies in some of the chip zones. So in summary, these are the expected results we want to find out.
Okay, so thank you.
Anticipating we would get, actually. Thank you.
So like your question, that means they have not yet got the findings, and that's why you didn't hear that. Okay, thank you.
Yeah, so thank you very much to the Health Information Officer from Eastern Region. Your question was about the interoperability of DIMS. So currently, I believe not only in your district, but my district too, we are also facing this interconnectivity between electronic health record systems. So this study was a foundation for us to continue. So what you just mentioned, we've already begun assessing the state of interoperability between electronic health record systems. So I believe when we are done with that study, we'll get to know why such challenges existing the electronic health record system in Ghana. Thank you. Then the second question was talking about the LIMS, the privacy, whether the privacy is secured. So what I can say is that for now, the LIMS system has been updated. The data is encrypted, so you can't just access it like that. Then I believe the access is also limited to certain practitioners and to healthcare workers within a health facility. Thank you very much.
Thank you. So, Director still wants to give some opportunity, at least one question or two questions to anybody who has a burning question for the presenters. We are about 6 minutes away from lunch, and he wants to offer that opportunity. Any burning question to the presenters? Okay, then otherwise I'll leave it to Director PPMED, to at least start by answering his question and then his comments will follow. Thank you very much.
Yeah, thank you very much, Andy. I think it's been a very brilliant time. We have professors here, my colleague directors are here, deputy directors, staff of the service, and from other agencies and from other countries. I think it's very insightful listening to these four presenters or researchers for that matter. Respectfully, to the organizers, if there's an associated Zoom and there's an online question, then we may have to take one or two. If not, then I proceed. Is there any online question? At least for fairness, we take one or maximum two. There's none. There's none. Thank you very much. That's good. So I think we started off with Michael Pukumbreku of the Ghana Health Service, who did geospatial insights for equitable healthcare access, optimizing facility expansion and service utilization. I think that was very interesting and insightful. I realized that they did justice to it, and at a point he mentioned some Zongo. I don't know the name. What is Zongo? Exactly. What came out is that here is a place that has ease of access, but they are not utilizing it. So it means that you have to drill and answer questions. Instead of that, assuming that they are not coming because it's far away, there are issues. And I think that was quite insightful. I recommended that geographical insights can drive more targeted and effective interventions, and that district directors, regional directors, and directors, or those who make decisions, should integrate geospatial planning. So for our colleague directors here, I think we really need to do that. The second presenter talked about the home visit app. That was Director Nanamre Kujima. The home visit app for monitoring, supervision, and evaluation of home visit and innovation towards achieving UAC. I think today we heard about chips, and been chips. But importantly, as I stand here with my colleague deputy director, it's important to know that currently the policy, we are building on chips, strengthening it, and then this networks of practice. I think I need to state it. Just like the Old and New Testament, the network of practice seeks to build on what CHIPS has done and bring in the sub-district and strengthen it, so that all this thing about geospatial thing for access on things will be resolved by leadership. So that for me was very instructive. And I like a bit about what my colleague director first said, and he said, is it home contact? In fact, this is a term, home contact or home visit. It's instructive. So all Dr. Fred is trying to say is that if it must be done, it must be done well. And I like a bit about what you said, that you are doing your best, but it can be better based on resource availability. And what I liked about this home visit was the fact that you know whether they are there or they are not there. I once visited the World Bank, and they were sitting on the big screen, and they knew where all the staff they have, tasked to do work with. So this is very important. And you mentioned the similarity to Chinese barefoot doctors. So I think that as far as Director of Policy Plan Monetary, we are thinking, if this is so good, we engage our colleague directors, we think through in terms of policy streaming. Do we adopt it? Do we take it to scale? Just like we took CHIPS to scale. So that's one thing we'll be discussing. So be ready with your regional director. We'll be discussing some of these things as far as this presentation is concerned. Then the third one was Abdul Jalil Muni, beyond service outputs, evaluating the operational efficiency of CHIPS in the Savannah region of Ghana using data envelope analysis. These were very mouthful terms, data envelope analysis and all that. It's very good. But I like the bit about the fact that it's work in progress. I hope I'm right. Work in progress. And what is instructive is that we said we can use this thing to actually bring out hidden underperformance, and also a more rigorous tool to assess performance. And that is fine. If it is so, we'll look at it and we'll use it. So we'll be looking forward to receive the results of your studies. So that is what we do. There are a lot of other issues. But quickly back to Upper East, where I just came from, where you have Director Cosmos, which is his son, Michael Yamuakun, talking about light waves health information management systems. And this is very instructive. Just like research, data is cross-cutting. And this is what we preside now. And just to put it, it's a brilliant work we've done. It's like you wanted to answer questions. Here you are, you realize that there are challenges. People are maybe not so much into computer literacy, and yet they are using the lips. Because there are people who have not used the computer before, they use mobile phones. So that is good enough. But it's good that you don't use anecdotal evidence. You need to have, whether it's descriptive, fine. It can be analytical. So I'm very happy to realize that you identified there were challenges. And one of it was internet. And that came from my good friend from Bono, who is the head of information I've worked. It's a problem. So back in Upper East, we were thinking of Starlink. I don't know about its feasibility and cost, but the Starlink was being used by my district out of Timpan. It was very fast and sharp, Starlink. So we'll be taking with our team, our deputy directors and other directors, is it feasible to use other means of getting, because internet currently, for us as directors, that's what we use for, so we'll be looking at it. And then also when it comes to light waves, there are issues. You know, we have to submit your data. Back at the regional hospital, my medical director told me when they submit the data, in terms of rejection, some of the things, it doesn't go well. So what do we do? So these are things we need to discuss. But I got to PPO just about 2 weeks ago, and the one in charge, I don't know the name, but he came to see me, and we discussed this frankly. I said, light waves have come to stay. So once it has come to stay, we need to discuss this thing dispassionately, and that's what we are going to do. And then the also issue which Dr. Andy spoke to is about the fact that academia is here. It looks like we may have to make, we talk about health informatics, that electronic medical records, there should be a way to bring to speed most of our staff, so that when they come already, they are handy. So these are some of the issues we have taken on board. There are a lot of others, but I think that it has been very brilliant listening to them and all your participation. You could have gone on and on, but I think our time is up a few minutes. So on my own behalf, on behalf of my co-chair, and of course the organizers, we thank the presenters and the audience for a brilliant set. Thank you, and God bless us all.
Thank you. So please, I think with the organizers, it's lunch time. So
any announcement?
Any announcements or something from them?
I think you should be clapping for us as we have said.
que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível
I think we can break off till 2, where there will be plenary session 1 and another post-gallery walk with a lot of other poster presentations. So I'm sure it's break. Okay. Thank you.
E constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months tomar decisão ao nível local.
De implementação que contribui em última instância tanto para a rede de implementação que contribui em última instância tanto para a redução da mortalidade quer tanto infantil quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people, 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day somebody will also help you.
You look at the problem, you try to find solutions through innovative ways. And one of the things that we did was to introduce a motor ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motor ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, portanto, nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day somebody will also help you.
You look at the problem, you try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a emergency public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow-on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I did family planning. Then I also treat manual ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recording in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. The researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or a coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital, e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. And I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a emergency public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those
Hello?
who are receiving services who know
Hello,
the
good
most
afternoon,
about
and
what
welcome
they
back.
need.
we believe that
I
there
hope
is a
you've
real
had a
value
good lunch.
of investing in the system, not just in the medical service
And,
provision, but investing
you are ready
in
for us to
personal,
launch into the
capacity building,
second part
health
of
system management, health information system,
our program
and
this
investing in the
afternoon.
referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers
the chairperson
are in place
for
to
this
measure
afternoon
and assess what
session is already here, has been here over the last 20 minutes and waiting for you. So we've given our colleagues out who are still eating some few minutes to wrap up and join us. This is a plenary session before we go to the poster presentation or walk, gallery walk. And then there will be the second parallel session or parallel sessions. So we have 1 hour, 30 minutes to listen to the African Health Initiative special session to be chaired by no other person than Dr. Kokua Uno Williams, the advisor to the Ministry of Health, who moves at the speed of life. No wonder that she was here much earlier than most of the participants.
achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in ARMS who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso.
I would like to plead with you that those who are at the back there, could you shift forward so that we can have a compact thing for the sake of the recording also. So if you wouldn't mind, kindly move forward so that we can have a closer interaction. Okay, so a couple of more, let's give them a few minutes to settle down. Please, kindly move this way, kindly move down, kindly move forward. Kindly move forward so that we can have a more closely knit meeting. So far, we have been doing very well with time management, and we want to keep that up. So we are moving into the afternoon program. There's a plenary session 1, which is on the theme Africa Health Initiative Special Session. And this will be chaired by the advisor to the Ministry of Health, Dr. Koku Auno Williams, who needs no introduction. He was here to deliver the keynote address. And this session will showcase lessons learned from the Doris Duke AHI-funded projects and programs and other innovations across Africa. This session will also foster learning and exchange of best and promising practices in health systems development in the different countries where the program is running, while benefiting from the expertise of sector researchers in the African Health Initiative Community of Practice. We have three distinguished personalities to do that. The Professor Ayaga Agulabawa, who is the program director and also the director of the Regional Institute for Population Studies here at the Hill of Knowledge. We also have Lisa R. Hedgestone. Wow, that's a great. Hedgestone. Anyway, Lisa, I cannot get Lisa wrong. So Lisa, from the Northwestern University. And then we have Kenneth Share of the University of Washington. I don't know if they are going to deliver via online or they are here in person. Online. Okay. So since Professor Bauer is here, maybe he would like to, they will start. Okay. Introduce it. Yes. Yes, so I would like to invite Dr. Kokua Uno Williams, the chairperson, to take over the session. Thank you.
Good afternoon and welcome back from lunch. As the MC rightly said, we have a plenary session on the African Health Initiative on health systems innovation. And I would like to, you have already introduced the three speakers on the way, so I will moderate this session, and then probably at the end of the session, I'll give some few remarks. But let me say that, as said this morning, the AHI, the African Health Initiative project, span over 5 countries with lessons learned from these 5 innovations in health system strengthening. 3 panelists since 2007. 3 panelists since 2007. And Ken was leading the project Ken was leading in Mozambique, forgive me, Mozambique, yes. Ken is a professor of global health at the University of Washington in the USA. So let me hand over to Ken. Ken, over to you.
Great. Well, good morning, everybody. And it's great to see you all. Greetings from Seattle, where it's cold and rainy, which I presume it is not in Accra. I'm going to make a few remarks about the Mozambique experience with the African Health Initiative. Are you seeing my note slide or the non-note slide?
We're sort of seeing where you see the 2 things at the same time.
Okay.
You know, your next slide and your current slide.
There, how's it now? Wonderful, thank you, Lisa. All right, so I'll probably take the next 15, 20 minutes to talk about the second phase of funding that we had in Mozambique through the Doris Duke Charitable Foundation. And as Koku said, in partnership with Ghana and with Ethiopia. Now, each country had a different intervention as they were trying to improve health systems, but all focusing on primary healthcare services. And ours was the IDEAS project, or Integrated District Evidence to Action Program, focusing on maternal, newborn, and child health. And the focus on maternal, newborn, and child health really recognizes that the bulk of primary healthcare services do focus on the health and of mothers and their children. So this is it was a cyclical, iterative intervention, which we call audit and feedback strategy, which had 3 components, and these emerged as components that were really important from our first cycle, 7 years of funding. And it came out of, emerged from that experience, and what we wanted to do was package it into something which was a more formal, cyclical process of improving data systems and using data for decision making. So the first component was to support facility and district readiness assessments, where at a district level, a district in Mozambique would have on average 8 to 15 health facilities, where twice per year we would go to a sample of health facilities and conduct data quality audits and service readiness assessments. And the intent of this work was really to understand, did health facilities have the basic structural requirements that they needed? Were they ready for implementing maternal newborn child health services? And there's a continuum of services there. And so we wanted to see whether the data was of sufficient quality, because if we're going to be basing decisions on routine health information system data, this is the GHIS2, then we have to ensure that data is a quality on which to base those decisions. And then also to ensure that they had the structural requirements met to provide quality care. Did they have the human resources? Did they have the required medicines, diagnostic tools, transport, etc.? Subsequently, and this is again cyclical, so we'd start with the facility and district readiness assessments, we would hold what were known as audit and feedback meetings. And this is where we'd get together district leadership, provincial leadership, and health facility managers from each health facility, public sector health facility in that district twice per year. And they would go through a process of reviewing performance using a standardized matrix to assess with DHIS2 data how they were achieving the implementation of government or Ministry of Health norms, and then look for areas of weakness, areas that they wanted to improve, and then develop action plans to address those problems that were articulated. And then the performance would be reviewed in subsequent meetings to see whether those action plans led to enhancements, and they'd be updated accordingly. And then we would select two low and one high-performing facility in each district for targeted support. And then that would lead to the third phase of this iterative cycle, which is targeted facility support, where they would review action plans at the health facility level. They'd provide supervision and supportive mentorship visits. And then funding was provided to address gaps in readiness and to support implementation of these action plans. So as Koku noted in his remarks, the second phase of funding from the Doris Duke Foundation really focused on increasing the scale of what was, in many cases, small district level or pilot projects in the first phase. And so the area where we were operating is in central Mozambique, Manica and Sofala provinces, where we've had long-standing collaboration with the Ministry of Health, and where the Ministry of Health had a commitment to improving primary healthcare services, as well as a regional research institute focusing on implementation research or operations research, the Bear Operations Research Center. You can see the health facilities that were included, and it was not all districts in Mozambique. It represented the largest districts in the most highly and densely populated districts, largely on this corridor going between Zimbabwe and the port city of Beira, as well as going north up on the road up towards Malawi and south towards southern Mozambique. In addition, what was, for me, quite a unique component of the support from the Doris Duke Foundation was the investment in capacity building, focusing on implementation research. And there are really two dimensions that were taken, or two dimensions of our work here. One is that we had, at a national level, through the Ministry of Health, funding for targeted implementation research to generate evidence on what are some of the determinants of and how to address issues that the health system was facing countrywide. And it was a process through which provinces would propose themes to the national level for further study. And two were selected for implementing with local research partners, either University of Eduardo Milan or the Bear Operations Research Center, which is part of the National Institutes of Health of Mozambique. And there was dissemination of research results. On the other side, we had also targeted capacity building through research training. So the foundation provided support for ultimately over 10 Masters of Public Health students in Mozambique, as well as 5 PhD students from Mozambique at the University of Washington over the life of the project. And they focused their thesis or dissertation research on related areas, so in the maternal newborn child health space, and largely connected to the intervention that was being implemented. And then project leadership, whether in Mozambique or at the University of Washington, provided mentorship as they developed their careers. And in addition, we had targeted in-service implementation research trainings for managers and leaders of the health system. So this took the form of annual, at least, trainings that focused on research methodologies, focused on analysis. Really, it evolved over the life of the project, but it really was intended to build capacity of managers in the health system to conduct implementation research. So I want to go through some of the results very briefly, just to give a sense of what we found. We structured our evaluation using the REAIM framework, a very common implementation science framework, which refers to reach, effectiveness, adoption, implementation, and maintenance. And REAIM is designed as to really give a full view of public health impact of the results of an implementation effort. So focusing on, when you put them together, those dimensions that are the active ingredient for public health impact. You may have a very effective program, but with small reach, which would have a smaller public health impact than if you had an effective program with large reach, for example. So I'll first go through the implementation outcomes related to the REAIM framework, and then we'll focus a bit on effectiveness. But we found that we achieved really fairly high reach when looking across the two provinces, though we only achieved a reach of 56% of health facilities in the provinces. They were the largest health facilities and covered 69% of pregnant women, first antenatal care visits, and 73% of fourth antenatal care visits in the entire two provinces. So the strategy, given that we did have some limitations with resources, that we only focused on those high volume districts, we were still able to achieve a larger or higher proportion of pregnancies in the two provinces, even though we only focused on 56 facilities. Adoption was quite high. Ultimately, 100% of districts and facilities implemented the intervention, which demonstrates the importance of having high-level leadership from the health system in any implementation effort. So this was really led by the Ministry of Health. The co-PI of the project is Quinish Fernandez, who's the Director of Public Health for Mozambique. And there were a couple of facilities that started late, but really there was high adoption from the beginning. For implementation perspective, and I'll go into this in a little more detail, we had fairly high fidelity overall, with 12 of 15 measures of fidelity achieving high fidelity. But importantly, 3 of those 15 measures had low fidelity, and I'll explain that in a little bit more detail. In maintenance was high at 1 year, 2 years, and by the time we got to the end of the project at 54 months, we tailed off to 71% of facilities implementing the intervention. Note that this also coincided with the COVID-19 epidemic, which did constrain our ability to continue activities as intended. So I mentioned I'd explain a little more around fidelity. So when you look at the different components of these cycles, where you conduct readiness assessments and audit and feedback meetings, and then they elaborate plans, we had targets for how many participants should participate, and then focused on flexible funding and supervision visits. We had high fidelity across all of those dimensions except for readiness assessments. We found that those pre-meeting readiness assessments, where we did data quality audits and service readiness audits, were really hard to do in a timely fashion. They were quite expensive, and ultimately, within the first 2 years of the project, we moved away from those readiness assessments, so fidelity to that component was low. We also, I mentioned there were 3 elements or indicators where there were lower fidelity. When you look at all of these micro changes, or those action plans that were articulated and tested through the audit and feedback intervention, we really can put them into the different categories of enhancing coordination and collaboration, providing information, education, communication to patients or the community, commodity stock management, information system management, involving community leaders, or health service reorganization. We found that despite having a large number of action plans developed and microinterventions articulated, that only 17% of micro-interventions were ultimately implemented. So there's what we learned from this is that we can get people together, we can come up with solutions, but not oftentimes those micro-interventions are not going to be implemented without sufficient support, and largely because the more micro-interventions that are planned, the harder it's going to be to implement the whole package that a health facility wants to implement in a 6-month time period. So some lessons learned from the implementation outcomes component of this work is that maternal health and child health managers can lead audit feedback processes, and they're positive about this type of implementation strategy. I did not present our qualitative inquiry where there was quite a high level of engagement from health workers and managers. That the specification of the problems and those solutions to problems, those micro-interventions, can improve, and really is the secret sauce for any sort of data for decision-making or health system improvement effort, is really having well-specified problems and matched well-specified micro-interventions, which is difficult to achieve at scale. We saw generally high implementation fidelity, but some gaps in problem specification, as I mentioned, those service readiness assessments, including data quality audits, and then with implementation of those micro-interventions. But overall, we did achieve high reach, adoption, and maintenance. And going forward, if we continue with this line of work, we really want to think about how the strategy can be refined to improve problem specification of micro-interventions, and then consider if we are going to continue with readiness assessments that we focus on fidelity in that area and completion of those micro-interventions. So I'm going to go quickly into some impact discussion. Now, we focused on, or at least had a broad, ambitious agenda for assessing effectiveness, looking at the impact on structural and process quality for services, looking at enhancements to service coverage, and then looking at neonatal mortality. We ultimately, given the data available to us, are enabled to look at neonatal mortality, so focused on whether there were structural and process improvements and whether outputs of the system were enhanced due to the intervention. So this was an uncontrolled, a non-randomized experiment. There was a control group because we were able to get NIH funding for the evaluation, but we did not randomize to who received the intervention and who didn't. Rather, we purposefully selected those districts and facilities that implemented the intervention, but that did go through a process of identifying matched controls in Manica and Sofala province, or Sofala province, as well as 2 neighboring provinces, and carried out a battery of surveys on an annual basis. So we'd have data to be able to say, did service readiness and did service outputs improve in the intervention area versus the control area? So we conducted a difference in difference analysis comparing change from baseline to end line in intervention facilities and districts compared with controlled facilities and districts. And we used the SARA instrument, which is a service availability and readiness assessment tool from the World Health Organization, to come up with an audit or assessment of availability of essential resources for the health system, and went through a process of coming up with a composite score for domains of medicine, equipment, infrastructure, and essential care materials. And I won't go into the modeling details. But what we found overall, and I'm going to draw your attention to the effect of the difference in differences, is, except for one area, the availability of essential maternal and child health care, that the intervention facilities outperformed those in control facilities, although only significantly for infrastructure. But there were large improvements that were underpowered to be able to demonstrate enhancement in service readiness. There was a decrease compared with control facilities. The intervention facilities had lower essential maternal child health care compared with those intervention facilities. We also looked at service outputs, and we conducted a controlled time series design looking at Manica and Sofala province and control province districts and facilities in neighboring Tet and Zambezia province. And we looked at 3 segments: the outputs of the health system. This is using GHS data, pre-intervention for 11 months, during the intervention for 40 months, and post-intervention for 12 months. and looked at 10 different outcomes that are available through the DHIS2 system. And that included, I'm not going to go through them all, but things like 4+ doses of IPT, of intermittent preventive treatment for malaria and pregnancy, tetanus vaccination, 4+ antenatal care visits, childhood vaccination, also at contraceptive new users and long-acting users for contraceptives. And we saw fairly minor differences between intervention and control districts and facilities. Some were significant in the positive direction, others significant in the negative direction. But I would say overall, fairly small differences and insignificant differences, or just mixed results of our interrupted time series analysis. So to summarize these elements I've covered so far, participation, supervision, and completion of microinterventions were identified as the main strategy components of this intervention. When we did sub-analysis and looked at effectiveness related to fidelity, we did see that effectiveness was positively associated with fidelity to these main components. And then we did note that in our effectiveness analysis that the facilities that had more action plan elements, where they identified more problems and more solutions, saw fewer improvements compared with those that were more focused and had better specified problems and solutions. And really, at the end of the day, it's great to plan, but it's completion of microinterventions. Implementing the solutions that a facility identifies is the main factor for attenuated or lower effectiveness. And so going forward, we really should be thinking about how to improve fidelity around implementation of microinterventions. And just some final thoughts on now 2 phases of Doris Duke Charitable Foundation funding, which I have to say has been some of the most rewarding work that I've participated in my life. The integration of research and implementation is really useful for ministries of health. It provides useful insights into the how and the why of research results and really makes results practical. If you're focusing research on the problems of the health system, you're engaging health system management and leadership in the process, and you provide results for them, it really is going to make a bigger impact than conducting research in isolation, if that's even possible. We found that layering research capacity onto this ongoing research endeavor was an efficient strategy for providing mentorship for junior researchers and also helped to achieve our project goals. Through having 5 Mozambicans go through a PhD program and over 10 through a master's program and focus their research on related areas to the IDEAS project, we were able to focus our research on our mentorship on the needs of these researchers and provide them with that practical opportunity so that they could deploy what they were learning in the classroom in a real-world laboratory setting. And then finally, we have to note that research capacity building takes many forms, and we should meet people where they're at. Some folks want to do a PhD, which is great. Other folks just want to get a sense of what does this implementation research area mean? What are some of its main components? And how can I, as an implementer, get engaged in research? So we really should be thinking about capacity building as a spectrum, where some folks are going to take a very deep dive and others will be dipping their toe. So I'm going to stop here and turn it back over to the MC. Thank you for participating.
Thank you so much, Ken. Thank you. Thank you for the brilliant presentation. What I would suggest is that we'll take the 3 presentations and then we'll open up for discussions. So Ken, hang in there, don't leave. We'll come back to you. Thank you. Now, our second presenter is Lisa. Lisa, I've known and worked with Lisa since 2005, I believe, and we are still working together. Lisa is the professor of medical social science at Northwestern University, also part of the AHI key pillar during the project implementation time. So let me take the opportunity to invite Lisa. Lisa, over to you.
Thank you, Koku. Always really a pleasure. And Kenny and I were sort of side chatting about the duration that we've actually been working together and sort of some of the really some of the shorter term, but also very much the longer term benefits. So let me see if I can get myself to my, somehow this is not, I'm not finding, try this again. Here we go. Okay, I'm assuming people can see this now in in the presentation mode. So I'm going to do something a little bit different than what Kenny did, which is sort of think a little bit back about what made the Africa Health Initiative itself an innovation and sort of a model of innovation investing in primary care, implementation, research, and capacity building. During my time at sort of more directly involved in the phase 1 for the Africa Health Initiative, I worked with the Rwanda team, supporting that work on the ground, as well as then sort of leading that work towards the end of it. In the phase 2, Rwanda was sort of off and running, and so was not part of the phase 2 countries, and I switched to being more on the advisory role and have continued to play a role for this last and final phase. So really wanted to sort of take a little bit to reflect back on what we learned about funding and research capacity building. But first, I really want to just spend just a moment to remember Lola. I met Lola when she was, I think, just a project sort of manager associate when she first came, and really had the honor and the pleasure of working with her and learning from her throughout the time of the Africa Health Initiative. Her loss is still deeply felt by her, both for her intellectual rigor, her ethical leadership, and her smile and laughter. And I will continue to miss her every time that I travel. So if we go back to what was funding like when the Africa Health Initiative started, so I'm going back to sort of the mid-2000s. And the approach at that point was it was focusing on either research or implementation. And those were sort of two separate things. The focus was also on a much more traditional study design, randomized controlled trials, fixed study. And there was very limited focus on primary care. It was much more focused on vertical programs. So if you wanted to get funded, you'd write an R01 for RCT of a very fixed intervention focusing on HIV or malaria or something like that. And embedded research capacity building, with the exception of one particular type of grant, was actually not very common, and certainly was not embedded within the grants. So there were a number of changes that the Africa Health Initiative made, and I think they're really things that we need to think about very carefully about, how we think about research capacity building and particularly partnerships moving forward. There were 3 components that the Africa Health Initiative sort of had said was for success, and the first was supporting local ownership of solutions. I think you heard a lot about that from Kenny's talk. Enabling learning systems, and building partnership-based work. And it was really a triad of an Africa country-based institution, a US-based institution, and the Ministry of Health. And I'm going to really focus on this first phase, which was the FIT, the Population Health Implementation and Training Partnership, that included Zambia, Tanzania, Ghana, Mozambique, and Rwanda. And I think the one of the key sort of quotes from that was that implementation science was an essential driver for sustainable health system strengthening and interventions. And this was then published in the second supplement. The first supplement, Kenny actually was one of the co-editors on, about lessons that were learned across the 5-country Africa Health Initiative. And again, remember back in that time when you talked about implementation, research, or science, people sort of looked at you like you were a little bit sort of slightly crazy, and that it wasn't really that wasn't really good research. And I think that the Africa Health Initiative really helped people understand what it was and how to do it. So when we sort of think about it, and this was a commentary that was written actually by Koku along with his colleague, looking at this idea about the early integration of implementation research to produce the right knowledge. And the quote from that is the Doris Duke Charitable Foundation's Africa Health Initiative was designed to produce this type of knowledge through embedding implementation research into the FIT partnership projects in the 5 countries with the goal of improving primary health care and population health. And again, I think just want to really sort of reflect on that. At this point, implementation research had already been developed, was still relatively unknown at that point. And the idea was that policymakers and implementers and frontline providers needed a different kind of evidence than what was being produced. You know, there's this quote of the 17 years between when an innovation is developed and when it actually gets into practice. I think it's much, much longer than that, especially when you're thinking about getting everything, you know, getting this care to everybody everywhere. And so again, this concept of how we think about embedding the research and having this concept of both policymakers, researchers, and implementers working together was something that was very important and something that I've seen expand over time. So one of the sort of core pillars of this was this concept of research capacity building. And again, I think, you know, people in the room have been involved in this, but just wanted to, again, reflect on why this was done and how this was done. And the idea is that it focused really both on short-term training, on degrees and on institutions. And as Kenny already pointed out, not everybody wants to go get a PhD. And honestly, not everybody should go get a PhD. But the idea is that you really wanted to drive more demand for data, more demand for evidence, whether you were at the front line, whether you were the policymaker, but then also to grow the next generation of leaders in implementation and the institutions that were needed to support them. A lot of capacity building will focus on the individual, but as we know from improving quality, it's not an individual. You really do need the systems and the institution. And there was a lot of really exciting work that actually happened. One of the sort of metrics, and this was this paper was led by Bethany Het-Gauthier, and she finding a significant increase in publications, including first author from the country and senior author. There had been a terrible misbalance because of that. And again, this using sort of the Cook's domains was the approach that they used. And I think I missed a slide. Sorry about that. There was just an enormous increase in the productivity of the number of papers that came out, the number of PhDs that were promoted, and a number of these individuals have gone on to be leaders in work moving forward. One of the people, for example, that I'm working with now, Will Brode, out of Zambia, who was one of the more junior researchers here now, is actually leading some very large initiative focusing on primary care and hypertension and HIV. They made a number of recommendations, some of which have actually happened and some of which still need work, that funders need to provide support, and support needs to be flexible to reflect the context and local capacity. Again, more traditional research funding often isn't that way, but the one thing about the Africa Health Initiative was they understood that we were learning. It was a learning health system, it was a learning research initiative, and things needed to potentially change. That effective research capacity building programs should include a continuum of activities, again, from the short-term frontline all the way up to the PhD. And this is certainly a philosophy that we're seeing in the D43 capacity building grants, and of which I have one now in Nigeria and in Tanzania. The use of research and research capacity building funds to strengthen existing research institutions when possible. So again, value not just the individual research, but also what's needed, whether it's pre-award, whether it's management. And research that is the focus of capacity building activity should be closely linked to the health program implementation. Again, this concept of embedding researchers, which used to be considered, oh, you're biasing the information as opposed to you're making the information more relevant, more usable. Mentorship, but really proper mentorship, is critical. But the provision of that may need to be creative, using virtual, and training the mentors is something that I've learned over time. And that we should also measure and monitor research capacity building outputs and impacts so that we are holding ourselves responsible for this in the same way that funders are. Well, here's some of the numbers. So all 5 countries used the funding to improve research administrative support infrastructure. There were 54 research trainings. This is just in the first also working with the Aspen Institute. So he was one of our first PhDs. The other things that Africa Health Initiative did was really allowed the countries to understand where there were emerging issues. And so under 5 mortality had really been a big problem. It was a huge focus and had actually dropped significantly. And Rwanda was actually one of the leaders in that drop. But then there was a recognition that neonatal mortality was not moving at all, and it was really stuck. And this was really not at a time. Now there's a huge amount of initiative. At that time, there wasn't that much focus on it. And I think this was work that was led in each of the countries. This is work that Hema Maggie, who's now at the Gates Foundation, also worked and actually spread some of the approaches to work in Ethiopia through the Institute of Healthcare Improvement, so showing not just impact but scale. And this was the quote from this paper, which was tackling the hard problems. Key lessons learned included the importance of focusing intervention components on addressing drivers of neonatal mortality across the maternal and newborn care continuum at all levels of the health system. So not just at the point of delivery, but across from the community to the primary healthcare center to the hospital. Matching efforts to improve service utilization with provision of high-quality facility-based services. So don't focus just on demand, but also service delivery, and the critical role of leadership to catalyze improvements of newborn health. And these were just some of the examples that we have from Rwanda, the All Babies Count initiative, which showed a decrease in neonatal mortality by combining both system as well as more traditional quality improvement, as well as then some of the work to scale up across Rwanda using one of the Grand Challenges Awards. And again, this is work that has really resonated and spread towards lessons learned as there's now this big focus on neonatal mortality. Again, some of the other lessons that we've learned from the Africa Health Initiative was a commitment to true equitable partnerships, critical success in capacity, knowledge generation, and use. It's also resulted in really important impact on networks. And there's a number of people like Koku, like Kenny, that connections were made that have resulted in ongoing capacity building for research, but also ongoing research and ongoing policy change. That combining implementation research was an important strategy and serves as an example for funding, although I have to say I'm a little bit disappointed. It's not one that a lot of people have actually cottoned onto, but I think it is a really important one to do that. The impact on both the individual, but also the health system, the networks, and the global knowledge cannot be underestimated. I think one of my regrets is that we actually never did a sort of formal network analysis, something that Lola and I had been talking about before her untimely passing, to really understand, how did this not just, help individuals move forward? How did this not actually move knowledge forward, but also the professional networks, the mentoring, formal and informal, that was so important. And I think very importantly, the great work continues. When I go back to Rwanda, people still talk about the FIT grant. People don't actually even know what it stands for anymore, but has really driven. And as we've seen, particularly during COVID and the post-COVID era, the importance of primary health care, to really reflect on the fact that this was really one of the first times that people viewed primary health care not as this sort of kind of existing lower level type of care, but an area that was critical as a platform onto which all of these vertical programs needed to be embedded. Those of us in the US are now facing a number of challenges, and these are challenges that have expanded to other countries, including Ghana. And I think learning from the partnership, learning from the approach towards equity, towards respect, and towards long-term capacity building is one that we should never forget. And we need to now more than ever focus on primary care, embedded research, and really country ownership and scale as we move forward. So thank you very much.
Thank you so much, Lisa, for such a brilliant presentation that provided an overview of the entirety of the 5-country project. Lisa initially was with the Rwanda team, but later provided overall support for the entire 5 projects. Now let's take the last presentation, then we can delve into questions and further discussion. And let me have the pleasure to invite Professor Bauer, who was also and is also part of the AH project team right from the word go. Sometimes foreign technology works better than local technology. They're trying to load this thing. So, but I know Prof. Kenneth will have to leave. So probably, is there any if there's any question that you want to the first presenter, we can take that while we prepare for the last presentation. Otherwise, probably I'll just ask Kenny if they have any concluding words to based on the presentation that Prof. Lisa just did. Is there any comments that he wants to make over?
Yeah, you know, it is rare to be involved in a series of projects that extend into decades. And I have to say, as myself, when I started this project, I think I have 3 children. I think my youngest had just been born. I was just joining the faculty, just finished my PhD, and I had a lot more hair and it was less gray. And to see where we are today, it's been such a blessing to be working with such great champions of health systems and applied researchers. And I love Lisa's comment on the social network analysis, because it would quantify what I think we all know, which is that we do have a network of thought leaders, and there's a lot of multi-directional learning. So from the Ghanaian leadership, we took a lot of their lessons learned around CHIPS, around their approach to scale of integrating Ministry of Health, Ghana Health Service, Ministry of Health leadership with research team, University of Ghana. From a Rwanda team, we stole a lot of their thinking around neonatal mortality and newborn health, and it's what I'm aiming at ultimately saying is, this next phase of Duke funding is all around building and maintaining a community of practice, and a community of practice has a lot of tangential benefits which you don't really realize until after it's over. And so I think what's really important in building that community of practice is really open, honest communication, and supporting each other. And that's what I've really taken away from this what was fit into the second phase of the African Health Initiative and into where we are today, where we weren't in competition with each other. It was never, except for one meeting in 2007 before the funds were given, it was never a sense of if we are behind on something, if we're not doing well, that we really can't talk about it because it will threaten our funding. It was always a community that was built around people doing different things in different places because of the context, and just having the ability to routinely get together, to check in, to share, to interrogate, really. It has greatly influenced my life and those around me and working in Mozambique. So I just want to, and I appreciate, Lisa, your homage to Lola Adidokin, because she really was central in all of this from the time she joined the foundation, which is right at the beginning of this initiative, until her untimely passing. And it was a great friend and colleague, and a champion for this way of thinking, this way of doing business, and really was deeply invested in the countries where the foundation was providing support.
Yeah. Thank you so much, Ken, for such concluding remarks. But because you went ahead and then at the University of Washington Global Health Program, you are doing some fantastic work. Since we have students here as part, maybe you want to say a paragraph of what you do now. What's your program like? The one that you run now in the University of Washington in Seattle.
Sure. So we have global health right now is under threat, and I'll just say that. We're living in a very trying times in academia in the United States. So a lot a lot of uncertainty surrounds us, but we have currently really two different types of academic training programs. We have a master's in public health and then a doctoral degree in implementation science. There's a sister doctoral degree to implementation science on health metric sciences, which is administered by another department, but we really run it as one program. So our doctoral program, which is fairly unique, provides 2 years of training on implementation research and implementation science methodologies, and then ultimately transitions into an individually led dissertation project, which is around the heft of 3 different papers, about 3 manuscripts. Overall, it's a 4 to 5 year program. Over half of our students are from Sub-Saharan Africa, Asia, Latin America. So we have a large contingent of international students. They tend to be fairly mature. They've come with previous master's degrees and really are mid-career professionals who want to focus, often pivoting into research from an implementation background or going from less applied research into applied implementation research. So if there's folks who are interested in learning more, that you could just Google implementation science, UW, global health, and you'll be able to see details of the program. Or reach out to me. Koku Bawa can give you a connection to me. And we have generally 5 to 7 students a year in implementation science. We just finished admissions and going to have 4 for next year. But we're going to have to see where things take us in the future. Like I said, things are quite uncertain in our academic environment.
Thank you so much, Ken.
I'd
Thanks
love
you
to have
so
a
much.
Ghanaian. We've not had a Ghanaian in our program.
Oh, you don't have a Ghanaian, right?
Not yet.
Not yet, because the reason why I asked the question is when I was the director of PPME, I've tried 3 times to get some of my staff there, but 5, 7 students a year is highly, highly competitive. But then if anybody's interested, you see me, will facilitate that and I'll take some fee. Thank you, Ken, thank you so much. Now let me invite Prof. Bawa to come and take your presentation.
Okay, thank you very much. So what I'm going to do is to give a little bit of reflections on the work that we did in Upper East when Kuku was the regional director there, and then transitioning there to the Northern and the Volta regions, and I'll give some reflections on some of the results that we got from the program. So can we move to the next slide? Oh, okay, I have all right, great. So I'll give a little bit background and then the research approach, the design and how we evaluated the program, some results and some conclusions and reflections and some of the key takeaways. So, I mean, I don't think that there's anybody in this room who doesn't know the program that Ghana delivers, the CHIPS program, which is the key program for delivering health services in this country, scaled up in 2000 following the initial work that was done in Avrongo and some of the replication work that were done in Nkwanta and other places, and then became a national program in 2000. As I indicated, the initial work was done in Avrongo when I was just very, very young, and I'm glad to have been part of that formative work that was begun when I just finished my first degree, and we did the initial trials, and subsequently there was some replication work that was done in Nkwanta, and I remember at the time Dr. Awunu was also then a young doctor, and he came to Navrongo and hijacked some motorbikes to go and and do some replication trials in Nkwanta. And subsequently, around 2000, it became scaled up as a national program. But as you are aware, as the program was rolled out nationally, it became obvious after some time of implementation that there were challenges. I mean, you can imagine that if you are delivering a program under very controlled circumstances like in Navrongo where the research was done, and then you scale it up nationally, obviously there will be some challenges at the scale. And so after about a decade of implementation, there was the need to evaluate the program. And so there was the Binka et al. Evaluation at the time. Professor Fred Binka was then at the School of Public Health as the dean. And so he commissioned a team that went around to try to get an understanding of what were the challenges that confronted the CHIPS implementation when it went to scale. And so there were about 6 key challenges that were identified, and then we took up those challenges and tried to turn them into research questions and see how we can address them. And that was working with the Upper East region when Dr. Uno was then the regional director. So there was the GHIP program that was introduced in around 2010 up until 2015 to try and understand that. And so that was what led to what we call the CHIPS Plus program, because there was the GAPE implementation, and then we identified some of the programs, and then we went to try to take that to scale. The donor then decided that instead of doing it in Upper East, we should take it out of the Upper East region and try in some additional regions. So we went to the Northern and the Volta regions at the time. But as you are all aware, the program, the program for delivering health services in this country, you have a 3-tier program from the community up onto the district level. At the lowest level is the CHIPS zones, or what they call the CHIPS compound, and then you have the sub-district, and then at the district level, and the various actors, you can see them to the right, where you have at the district level, the district health management team, the sub-district team, and then the frontline workers. So that is, as you are all aware, the structure of the program. So, but in the course of the implementation of this program, nationally there were challenges, and so what GHIP did was to try and address some of these challenges that confronted the implementation of CHIPS and subsequently what we call CHIPS Plus. So CHIPS Plus was a program of activities that was aimed at addressing some of the challenges that confronted the CHIPS program at the district level. And it was implemented in partnership with the Ghana Health Service, with us at the Regional Institute for Population Study leading the evaluation of the program. And at the time, two of the universities that were in the 2 regions that were implementing the program. So in the northern region, we partnered with UDS, and I'm happy that our UDS partners are here. Dr. Dennis Chiraura was the lead person at UDS leading the program. And then at UHAS, we partnered with Hubert and Co. And I see that Hubert has come with a large team of students from UHAS, a delegation of about 19 people. So Hubert, thank you for coming with that large contingent. So we implemented this together, the service, us at RIPS, and then the two universities. It was a simple program, and what did we seek to do? I mean, as I indicated, the objective was to try and address some of the key challenges that confronted the implementation of CHIPS. But we didn't go through the traditional route. What we did was to deliver 2 basic strategies, very simple, but quite innovative. One, to foster what we call, learning exchanges. So we had the district learning exchange program where we brought districts into to districts that we identify as doing very well in terms of implementation through our initial assessment to come and learn what was happening in those districts and try to take some of the good lessons and go on and implement. And then to also then look at what innovations that are there and then to take those innovations into specific contexts in each of the districts to implement. So we had what we call an embedded design. And the design was to have all stakeholders involved in the program. So we dealt with the policy makers, we dealt with the implementers, we involved the researchers to get the monitoring and evaluation done, and then so that we can try to use evidence to improve the system. In the process, we try to build some capacity, especially among the frontline workers. And then in doing this, we had a very strong some capacity, especially among the frontline workers. And had a very implementation partners by fostering a lot of meetings and exchanges and just discussing some of the issues that were confronting the sector. And in this process, to try to manage all that knowledge that will gather around all the implementation plan partners to try and see how we can synthesize that knowledge and then, deliver it back into the system to try and improve the system. So in terms of design, we had a very basic design. So we had what we call system learning districts, and the system learning districts, as I indicated, were the districts that we identified, supported them up to a level where they became model districts, so that those model districts then become centers where other districts could go and learn and go and implement. So those then, so on the one hand, we had those system learning districts. Then we brought districts from in each of the two regions, and then we brought other districts to come for a period of 2 weeks, and in the process we organized a competition to see those that will get some funding, and then others will just learn during the period and go and implement. So we had districts that came through the system learning district for some training, and at the end of the training, they all balloted, and some of the districts got funding, got what we call catalytic funding. Some of them didn't get. So we had districts that had what we call catalytic funding, and other districts just benefited from the training. So the districts that had the catalytic funding benefited from both the training, but also got some small funding to go and implement innovations. So it means that they had, in addition to the training, they had the advantage of getting funded to try and implement some of the ideas that they learned. And those districts that didn't win the funding just benefited from the training and then go and then try to implement some of the ideas that they learned from some of those districts that they learned in the course of the peer exchanges. And so the map to the right the different colors show the different configuration of districts. So you had the system learning district that had the red, and then you had the other districts in the different configuration. And we implemented in both the northern and then the Volta region subsequently, what is now the OT region. So some of the peer learning and innovations that were developed just centered around the building blocks of the health system. So the building blocks, as you know, you had leadership and governance, service delivery, health system financing, health workforce, medical products, vaccines and technology, and then health information. So some of the innovations centered around the building blocks. And some of the examples of some of the innovations that were implemented include, facilitative supporting, which is already being done by the service. We just try to improve that process. Annual sub-duty review with communities, use of the e-tracker and offline DIMS to promote data use for decision making. And all these were some of the innovations that were done in those districts. So after implementing this for a number of years, we had to evaluate. But prior to even, starting the program, we had to do what we call initial assessment through baselines to be able to get the baseline situation before the introduction of the interventions. And at the end of the intervention, we did end-line surveys to be able to measure the impact. So we had mixed methods, qualitative system appraisal, which was led by our team, led by our colleague Dr. Baini and her team, Mauli, who is now at UHAS. And so we did a baseline survey, qualitative surveys. We did a midline and an end line in all the districts, both the system learning districts and then the trainee districts with catalytic funding and the trainee district without catalytic funding. So we did the surveys in all of that. And then we had a household survey. We did a baseline and also an end line in 14 districts across the two regions. Then we also did a health facility assessment survey. And the health facility assessment survey, we also did the baseline and end line. So what we did was we took information from all health service provision points in the district and within 5 kilometers of all district borders. And then we collected information on personnel, infrastructure, supplies, and functional equipment. So that was how we went about evaluating the program. In terms of analysis, we did thematic analysis and thematic content analysis for the qualitative survey. For the quantitative evaluation, we use difference in difference framework. You've seen that the algebra that was shown by Kenny Share when Kenny presented on the most of the Africa Health Initiative. Because of the design of the programs, we all utilize difference in different frameworks, where we collect data at the beginning, we collect data at the end, and try to find the difference that would have occurred between baseline and end line. So that's what we did to be able to identify the impact of the project in all the sub-configurations of the design. And our primary outcome was under 5 mortality, but we also had other secondary outcomes or intermediate outcomes, such as fertility and life-seeking behavior, and also we use descriptive analysis. So I would provide some of the results. So this is our qualitative system appraisal sample. I'm not going to go into the specific details of all the total numbers but you will see that at baseline, we did a total of 450 and at the midline 419 and end line 319 qualitative interviews. For the women's survey, we collected information for a total of about 11,000 women at baseline, with almost 8,000 information on 8,000 children. So that was a very large sample. So in terms of the qualitative results, we found out that there were a lot of improvements by looking at going back to interview people. We had a lot of people testify to some of the improvement in the availability of logistics, equipment at end line, improvement in service delivery, provision of desired infrastructure. These were some of the things that we we discovered. In terms of the impact, as I indicated, we use a difference and difference framework using regression analysis. And so here we did separately for the Volta region and separately for the Northern region. For the Volta region, you can see that if you look at if you just compare the comparison districts, which is in blue, to the system learning district, both the trainee and system learning districts had improvements in mortality. In other words, there were reductions in mortality, but we didn't see any significant differences in terms of the statistics. For the Northern region, we see similar results, but for the Northern region, we saw statistically significant reduction in particular for under 5 mortality, especially for the system learning districts, which obviously this is what we expected, that the system learning district will do much better. So to summarize, in terms of the impact evaluation, we realized that there has been there were reductions in both fertility in both the Northern and the Volta regions. We see a positive impact in the health-seeking behavior indicators that were some of the secondary outcomes that we're interested, and we also see improvements in under 5 mortality, as I showed in the results. So, just to conclude with, the results shows that there have been changes in mortality, particularly survival, fertility, and important, and some of the indicators. We see, improvement in investment in basic equipment during the implementation period, and then we see that the peer learning approach has been very effective for districts to go and learn from their counterparts that are doing well, and we see that has been very, very effective. But we also noticed that even at the end of the program, we noticed that some of the problems that were identified at the beginning continue to persist. Okay, so the 3 takeaways is that building capacity is very important. There is the need to foster an enabling environment, especially for the use of data for decision making, and also that there is a need to share knowledge, especially among peers, so that people can learn from some of the activities that are going on in other places and are going on well, and then others can learn and implement in their own areas. Thank you very much.
Thank you so much, Prof. Bauer. We have 10 minutes basically left to conclude this session, and so let's be snappy and quick. Is there any? So the last slide that was shown, you will see a publication at the end. That is that compendium of all the papers and all the publication that has been done as a result of this project, and I think it's available also online to see the various aspects of the research, both primary health care, ideas, quality of care, health system strengthening, all of that. Several papers. Lisa, are you still there with us? Oh, yeah, yep. Great. So probably we'll give you just a minute or two to say anything you want to conclude based on the 3 presentation and reflection.
I mean, I think, again, it really showed the longer term impact of people looking to improve healthcare access and delivery. And, the real importance and the role of integrating research into what we do, creating more generalizable knowledge that can then be used. I think, the Ghana has always been a very important example of how you could start from something very small, the original Navrongo work, and then, through really close collaboration with the government, use this as a way to scale up to have, national impact, but continuing to learn. So CHIPS went national, and then the idea was, okay, how do we make it better? How do we make it more effective? So I think it's a really great example of, when done well, research is not just something that results in a paper, but that can really drive change. I always remember, Koku, you teaching me that if somebody came to you with the results of a perfect study and you'd never heard about it, and they sort of hand it to you, and similarly in Rwanda, Agnes used to say, if I first hear about a study in Lancet, like, that's a problem, in Rwanda. So again, also emphasizing the need for really clear stakeholder engagement at the community level, at the local level, but then also at the national level, and updating frequently, often, and engaging to really create this kind of long-term change. I'll also say, I'm now the director of the Ryan Family Center for Global Primary Care, and we use this example as a really important one about how do you truly strengthen the network of care? So it's not just community health workers or facilities, but again, this whole idea of a network of practice or a network of care that I think has also really been informed by or strengthened by this work. And similarly, I think in Mozambique, the idea, there's a lot of QI that happens that does little change and then it goes away. And the idea about really thinking, using data to understand, did it work? And if not, why didn't it work? And has been really, really important. So again, just reflecting back on, how you do research and the questions that you should be willing to look at, and then thinking about sustainability and scale from the very beginning is a really important lesson for people who are doing this research, whether you're starting in the middle or towards the end of your research career. Thanks.
Thank you so much, Lisa, for that. And thank you so much for your time, for joining us today for this panel discussion. We know that time is of essence, but then you find time to do that with us. Thank you so much, and wish you all the best.
Sure. Always a pleasure, and actually looking forward to being in Ghana in the end of June. So
Yes.
Hopefully we'll see you then as well.
Sharp. Thank you. Thank you. Thank you so much. Let's give it a applause. Now let's come back home. And is there any question, any clarity, any? Yes, please.
Thank you. Yes, my major question is, from the findings, we realize that, like the provision of equipment, all these things are very major intervention areas. And when learning from CHIPS, when I was leading in the network of countries, I noticed that the people who are in charge of this equipment and supply groups were lagging behind the policy, the main drivers of the policy. So this equipment and all those supply chain, SSDMs and infrastructure groups were far behind the policy. So I don't know whether in our work, in terms of collaboration, we've looked at how to, in some of these interventions, how to look at that aspect of it. Mm-hmm. Thank you. Over.
That's a good one. Is there any other? Let's take one or two, three. Then we can, unless there's no more, then I can try to. Yeah, I think that's a very good question, and it's always the case when you talked about health system, but people are working in silo. You need to really have an integrated approach, bringing everybody on board, making sure that there's always this connectivity within the various aspects of the health system. And the good thing about it is that if you're approaching health system innovation, you need to keep your eye on the ball around the health system building blocks. Those 6 pillars are very, very important, that they're interconnected. And I understand that you may start a policy, you may start an implementation, and then realize that 1 or 2 legs are missing. And it's always appropriate to go back to the basis. We always talk about think small, think big, but start small. How do you connect? So yes, in the GHIP implementation, for instance, we had to take it came out of the report of the review of the CHIPS implementation, and then what are the challenges, and then we package the challenges. And then once you take one challenge, you want to draw the line, where you need interconnectivity. But it's always a challenge. But then the major thing is that you must have that health system mindset. Otherwise, you start running alone and then realize that it's not working, even though you put in a lot of efforts, because people might always draw you back. So it needs also what I talked today in health system innovations, negotiations, negotiations, and working together as a team. That challenge will still be there, but then I think there's a way that we can look at it in terms of having everybody at the table at the beginning. Sometimes we are so eager to run. You know, I had challenges some time ago with the university when I was director of policy, and we're looking for solutions. And yet you have all the solutions in the university. And then you come and say, oh, you know what, we just done that. I heard you talk about this project, this program. You know, we have done this research and the results are shown clearly. Why are you now coming to me? When you were thinking about the research, you didn't involve me. I'm not aware. I've finished my budget. I've messed up because you haven't given the result. Now I'm running and you are saying, I have the result. So sitting at the table sometimes is very important. And that's why when you look at all the 5 African health projects, it was the ownership was the leadership of the service, the public service. The ministries were running it. And therefore, you found a home for it that you can actually navigate that space to be sure that you are able to address those hiccups. I think that is one of the other ways to be able to approach that. Thank you so much. Brilliant question. Is there any otherwise? Thank you so much for the opportunity. And I will invite the MC now to take over. Sorry for we spent more than the time that we allocated. Thank you.
Let's give a round of applause to our able chairman for even though technology got in the way, we managed to stay within our time. 2 quick announcements. Number 1, all travel award recipients and mentees should kindly see the people at the back there and register themselves. Then number 2, I used to not believe in witchcraft until this afternoon. The organizers have been drawing my attention that there's someone that I need to introduce, but each time I climbed here, I forgot his name. So he's in the person of Professor Martin Nyaba Adokia. He is the Vice Dean of the School of Public Health at the University for Development Studies in Tamale. Professor Adokia, where is he? Okay. Sorry that, but please, as more and more people come, just draw my attention, then I would introduce them. Some people are shy, they say they don't want to be mentioned openly. That's okay. So we would break up now and go for the gallery walk, and also are doing poster presentations. Will take us through what they have brought, and then we can ask a few questions and then make comments. And then we transition into a cocoa break. Here is coffee, but I read it as cocoa. Transition to cocoa break for 30 minutes. Then at 4, we will resume the parallel sessions. And then, please, I think you already have the program and you know your parallel sessions. And then otherwise, the breakout rooms, the ISSER Auditorium, which is up there, so now you know where it is. The seminar 2 is over there. Where is the ISSER Auditorium? Oh, this is the auditorium. In the morning, it was the conference room. This time is the auditorium. That's okay. So can we just move out now for the poster walk? Then we go for our cocoa break. Thank you.
How come the lunchtime they do the play? No, after lunch they don't come back. Why? They don't come back. So when
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better, and using data to drive that process.
O projeto tem fundamentalmente 3 componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local, da unidade sanitária, e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I had a passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day someone will also help you.
You look at the problem and try to find solutions through innovative ways. And one of the things that we did was to introduce a motorcade ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recorded in the communities. We addressed that problem by providing what we call the motorcade ambulances. This is a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a emergency public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
We believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
A pesquisa de implementação é tida como uma das prioridades do Ministério da Saúde, dado que é a melhor forma de identificar, portanto, as fragilidades de resposta do sistema de saúde, tanto nos diferentes níveis do sistema.
The IDEAS project covers 12 districts, about 150 health facilities, and covers a population of about 3 million people. It's creating a mechanism so that there's a better understanding of what we are doing and how to do it better and using data to drive that process.
O projeto tem fundamentalmente três componentes. Tem uma componente de formação, portanto, de recursos humanos, tem uma componente, portanto, de financiamento, de pesquisa, de implementação, sobretudo com enfoque para o nível, e uma terceira componente que é de melhoria de qualidade de dados e uso nos processos de tomada de decisão.
A informação é colhida ao nível da unidade sanitária pela enfermeira e passa depois para o resumo.
Por exemplo, se ela consegue notar que das 100 mulheres que vieram fazer consulta pré-natal, só consegui fazer testagem em 80, porque os testes acabaram. Acabaram porque eu, enfermeira, não pedi, acabaram porque o sistema não tem.
E eles têm essa capacidade de fazer essa análise ao nível local da unidade sanitária e constroem os seus gráficos para poderem tomar decisão ao nível local. Depois o resumo é enviado ao serviço distrital e do serviço distrital essa informação entra numa base de dados que a direção provincial tem acesso e ao nível do Ministério também tem acesso.
Tudo isto depois leva à realização desta reunião.
Every 6 months, the meetings bring together district and facility level managers to review performance and follow on supervision and financial support.
É um momento não só de apresentação de resultados, mas ao mesmo tempo é um momento de partilha de experiências, portanto, entre as diferentes unidades sanitárias. Estas reuniões culminam com a elaboração, portanto, de um plano de ação que é fundamentalmente um instrumento que guia a ação, portanto, ao nível das unidades. Este programa contribui para o reforço do sistema de saúde através do treino de profissionais e de financiamento, portanto, de pesquisa, de implementação, que contribui, em última instância, portanto, para a redução da mortalidade, quer, portanto, infantil, quer neonatal.
All my life, I've worked in the district level, I've worked in the community level. I've seen so much suffering in the communities. Traditionally, we've seen people who come and say, I want to do something on malaria, I want to do something on EPI, I want to do something on diarrheal diseases. Strengthening health services in Ghana is very important. Previously, we had focused so much on the clinical services, and therefore we built a lot of hospitals, thinking that the hospitals would solve the health problems. But very few people go to those hospitals. If you look at the entire country, we have over 27 million people. 60% of the population in Ghana live in communities. And that is why there's evidence that if you put up a regional hospital, you are seeing only about 20% of the population. You need to mobilize communities and make sure that they are part of the service delivery and finding solutions to issues that are affecting the entire health system. We are focusing on community-based primary healthcare system as the basic primary healthcare vehicle to drive systems at the community level. That is what our health system needs.
I'm a community health officer because I have the zeal to work, to help my community, to help Mother Ghana. I render child welfare clinics. I do immunization. I do family planning. Then I also treat minor ailments. I have the passion for the job. I'm doing it with my heart. It's humanity. You are helping somebody. One day somebody will also help you.
You look at the problem, we try to find solutions through innovative ways. And one of the things that we did was to introduce a motor kidney ambulance service to serve women in terms of referral from one community to the other. Women were dying, babies were dying. Most of the deaths were recording in the communities. We addressed that problem by providing what we call the motor kidney ambulances. It's a local initiative.
With the introduction of the motorcade to this place, the community has really done well.
If you do something successful, there's always a need to carry on. We have a major public health system working, we have volunteers working, the nurses have adequate equipment, they have their clinics, they're working. Any country that looks at our health system or look at our program should be able to apply it.
You can't ensure the health of a population one disease at a time. You need to have a robust and functioning healthcare system.
Health system strengthening is an effort to invest in all the elements of a health system, from service delivery to research and decision-making around data, to developing prevention efforts, to setting up policies that can be sustained and endured over the course of different political environments.
In 1998, when we were giving out our first grants, the AIDS pandemic in Africa was exploding.
And the international community responded with more investment than anyone ever imagined. But what they neglected was that there had to be a system to carry these initiatives.
In order to deliver health care, all aspects of a health system have to be functioning. You need nurses, you need doctors, community health workers, local clinics, hospitals, ambulances. So we started thinking about trying to do something that would strengthen the entire health system. It's an enormous challenge.
In the first phase of the African Health Initiative, we put out an open call for partnership proposals from 11 countries. And after quite a long review process, we narrowed down and awarded grants to pilot projects in 5 countries. Those countries were Ghana, Tanzania, Rwanda, Mozambique, and Zambia.
For the program to work, it needed support and agreement from all the levels, national, provincial, down to the people who have day-to-day oversight of the delivery of services.
We view data as one of the ways that a health system can be best informed.
You have to be able to see what you've done. You need a health information system. You have to be able to have the ability to examine those data and to course correct. That requires leadership and the ability for local actors to make decisions.
Not all of the projects were successful. From that, we decided to have a second phase of the African Health Initiative and to make some changes. We required that an individual from the national government commit time to leading the program. The second important shift was a recognition that we wanted researchers, practitioners, and program managers to come together regularly to talk about data and research and evidence use, and to talk about what the data was telling them in their communities. It's our intention to build that culture of review and thoughtfulness when making decisions around service delivery.
This is not a high-cost investment, but it's not one that can be achieved without resources. We need funders to start thinking about coming together and enabling projects to be implemented, not just one district at a time or one province at a time, but on a national level.
The legacy of the foundation lives in the people that we've supported, not only in the lives saved, but in the researchers, the policymakers, and the practitioners who've embodied this approach. My greatest hope is that the countries where we're investing are able able to continue this effort in strengthening their health systems after the Doris Duke Foundation funding comes to an end.
How do we really advance the health of women and children in developing countries?
This work is so challenging that without partners, there's no way of supporting resilient health systems in lower middle income countries.
I think it is really necessary to come together and work for the common goal,
which is to improve health outcomes for individuals in sub-Saharan Africa and beyond.
We fully understand the resources in maternal and child health are not limitless. And so part of our partnership is to support countries in their path to self-reliance. We have to work with all of the stakeholders on the ground. We have been working with the Doris Duke Foundation on the potential benefits of implementation research.
Approximately 22% of child and maternal mortality can be reduced by investing in discovery research, whereas by focus on implementation research, 66% of mortality can be reduced.
It's those individuals who are leading and managing health services and those who are receiving services who know the most about what they need.
we believe that there is a real value of investing in the system, not just in the medical service provision, but investing in personal capacity building, health system management, health information system, and investing in the referral level care.
The answers lie in the countries where we're investing. Researchers collect data that's meaningful. Practitioners bring the lens of what the challenges are, what the opportunities are, and what the needs are. Policymakers are in place to measure and assess whether or not they're achieving the goals that they set out. And they aim to train the pipeline of workers in the workforce.
Working with the African Health Initiative has helped grantees to develop very clear policies through efforts that were supported by implementation research.
These are examples of where bringing together a partnership or coalition is absolutely critical. We serve a dual role, both as a technical supporter to developing countries in the way that they program, and a funder.
Global partnerships can help identify funding and help support implementation research.
We have partners and colleagues in arms who recognize the unique contributions that they make towards this broader vision of strengthening health systems. We need those partners who fund and support infrastructure development, who support single disease programs, who support data use. We need all hands on deck.
Hello? Welcome back. I hope you have warmed up the system or cooled it down for us to go straight into the panel sessions. We have those who will be in here working on the theme community health and primary health care. The moderator would be Mauli Kushito. Oh, you are right there. Thank you very much. Of the University of Health and Allied Sciences. ISSER Auditorium, okay. And we have Professor Adokia will be presenting. Dr. Dennis Chiro will be presenting. Haruna Mushi Musa. And then Nko Sefayo Thembie Nkambule. No, Nkambule. Maybe it will be online. That might be an online presentation. Okay. The ISSER Seminar 2 up there, we have quality improvement and patient safety. The moderator is Lily Kobi. The moderators would be Lily Kobi and Lawrence Oforibuedu. one of the University of Ghana, and then the other one, Ghana Health Service. Then Bridget Setonyo Lecha, and then Jacket Nsavimana representing, Stephen Kuku, and then Enyu Gatene. Okay, maybe that will be online. And then at the RIPS computer room over there will be health systems research from early research perspectives. That will be where all the young people will be presenting. And then we have Caesar Agula would be the moderator. Celestine Mau Femo Fofwe, Alberta Edu, Janice Mubi Brownie, and then Joseph Sam. So please, you are kindly requested to break up into your groups so that we can keep to our time. Thank you very much. Mauli, are you calling your people to order?
Good afternoon, everyone. This is the last session, and so I just want to plead with everybody to at least come a bit closer to the front so that we can have a more compact meeting, as Dr. Francis Santua said earlier. So please, I want to crave your indulgence if you can come a bit closer. That would be fantastic. Community health is, for me, if a policy will work, that's where we will see it. That is where they say, if that's where the rubber meets the road. That is where, after all the high-level conversations and everything, that is where we would see if it's actually working on the ground. So this afternoon we have 4 very important presentations. For me, I want to talk about, so there are 4 very important presentations. The first one is Professor Martin Yaba Adokia, and then as has already been said. The first time I encountered Prof, quite an interesting one, was I sent some submissions, and at the review, they said that I needed to reference some of Prof's work. So that was the first encounter. That was quite some time ago. And oh boy, what a wealth of publications and wealth of work that was available. So from that time, I've been reading and following closely. So some of us, we have been your secret admirers from afar. It's great and important for us to meet you in person today. So Prof, you will do the first presentation for us today. And is it possible for us to just take a little step closer if it's possible? That would be so great. So without much ado, let me invite Prof to take the stage, and let's give a round of applause as he comes to do his presentation. Thank you very much. The presentation is for 15 minutes.
Good afternoon. I know we have just eating, so we may be struggling to cope. So I want to thank you for the introduction. As I'm about to start, I wanted to find out whether somebody will give me his or her glasses, because the speakers all wore some glasses this morning. Unfortunately, I don't have some. The second thing is that I shouldn't be giving this story, because what I'm going to talk about, I was only 15 years old when this story began in Evrongo. So today, I will narrate a story that I'm slightly older than. And anything that happens, I've been part of this journey, and I'm happy to continue to journey with the CHIPS concept going forward. So our presentation this evening will be on the CHIPS in terms of its functionality. We'll look at the composition of it in terms of gender, equity, and social inclusion across 6 districts in northern Ghana, particularly the northern region. Oh. All right. On the board, you see why I said I was only 15 years when this started. In 1994, when the whole project began. And then by 1999, the policy became national, and then the program launched nationwide in 2000. What do we have to say? It is the main entrance or the strategy for the primary health care in Ghana. And what it intends to do is that it brings health services to the doorsteps of all those who want to use them, first by removing the delays. The delay to reach any health facility is removed just by introducing this. We believe that CHIPS as a concept has been very, very successful. We have a lot of information to demonstrate that this is successful. What is common is that everything needs revision, review, needs refreshment or refresher training. So that is what brought us to this. If we say CHIPS as a concept worked, it reduced infant mortality, it reduced fertility. How did that come about? It came out as a result of an intervention and operations research using 3 different sub-districts. And then within the sub-districts, they divided it into 4 cells. And out of the 4 cells, one of them proved to be successful. It says that for that cell that produced a lot of success, it contains 3 components. The first one says that a CHIPS compound where a community health nurse stayed there, and the nurse was readily accessible in the night or daytime to render services during emergencies made a difference. The second component is that there were volunteers who assisted outreach activities. So assuming there's no compound, there's no facility where people can go there and receive services. But the volunteers can go out and support the health workers to provide the services that are needed, even within the compounds. It made a lot of difference. And then the third component says the community health management committees. For those who are not very familiar with the CHIPS concept, it is supposed to be made up of 15 individuals selected from the communities that are within the CHIPS zone. And then they are selected into this committee based on unique features, characteristics, qualities that the beneficiaries think will help them make a difference. So the third component was this. This committee oversees that community members mobilize resources, they actively participate, And then at the end, they establish a bridge where both community health nurses and the volunteers make communities feel happy, relevant, recognized, therefore they accept the services that health workers want to provide for them. With the success that I've already mentioned, that mortality reduced, fertility reduced, is everything so good that we cannot do anything? And that brings us to what we want to share with you. That some of the CHIPS compounds over time, the composition of the committees changed. Some died, some migrated. New CHIPS compounds were built. Therefore, the membership lost the skills, the competences, and the capacity that was given to them. That is to say, if you look at what happened in Nevrongo, with intensive research, intensive supervision, then people were able to see massive change. As the concept became national, it scaled up. Then you can see challenges, weaknesses, because there are different levels of accepting, adapting, and then implementing the same strategy. So USAID invited for sub-grants in 2023. And then they said, we know that CHIPS as a concept has come to stay, it has made a difference, but there's a certain part of it that needs to be strengthened, and that is the community health management committees. So collaboration is important, working in partnership is important. So USAID came in with the Ministry of Health, Ghana Health Service, and then said, can any other researcher or institution that wants to help to strengthen the capacity of these people come for sub-award? And then we presented ourselves to do that. What were we to do? That they will go to northern region out of the 6 districts that USAID identified. They also identified specific CHIP zones, ranging from 13 CHIP zones per district to 15 CHIP zones, that will work with them. What we'll do is that we'll ensure that the committees are able to advocate for quality health care. That is, if there's a CHIP zone, the committee members should play an active role, strengthen and advocate among community members to come forward and utilize the services. And where there are gaps, the committees should help the health services to improve. And then with the continuous improvement, everybody gets better health outcome. So for us to be able to start the training, we needed to do first assessment. We needed to find out where are we now? Can we benchmark it before we start the intervention or the training? The first one we wanted to do was to determine the situation of the committees in terms of gender, equity, and social inclusion. And for us to determine that, we came out with a cutoff point. This cutoff point was proposed by USAID, that if you have 50 members forming a committee, at least 40% of them should be women. So we wanted to find out whether these committees are meeting this benchmark. Then the second one was for us to describe the capacity of the committees to use a tool that has been developed for assessing health facilities. That facility is what we call the Ghana Community Scorecard. It has a 9-point indicator that they use to score from a scale of 1 to 3, and then select 3 points for implementation over a period of 3 months. So we wanted to find out that. The second one we wanted to find out from the committees was the use of the scorecard to conduct it. Do you know it? Are you able to use it to conduct the assessment? And then the third point is that, if you're able to do the first two, can you use that tool
to prepare a community health action plan that you will implement over a period of 3 months. For our colleagues from Malawi, this is our country. It's located in West Africa. For the rest of us, we know that we are in West Africa. But for our dear friend, Dr. Leonard from Malawi, we are happy to tell you that. Currently, we are 34 million, slightly higher than Malawi, which is still in 20 million. And for easy administration and governance, the country is divided into 16 regions and about 261 districts, municipalities, and metros. But when we come to where the study was conducted, that is the northern region, it is divided into only 16 districts. And then we can see them, 1 metropolis, we have 4 municipalities, and then the remaining are districts. So if you look on the right side of it, the yellow color depicts the region, and then the green color represents the 6 districts we were to conduct the assessment and then implement the project we got from USAID. How did we do the assessment? We used both quantitative and qualitative approaches. We went in and interviewed at least 1 community health officer per CHIP zone. And then within the CHIP zone, we also tried to interview another health worker or 2 other persons. That gives us a total number of 176 plus the 86 CHOs. These days, nobody wants to be doing manual things, so we try to use Kobo Collect to reduce and save time and also minimize errors. For the quantitative part, we conducted only key informal interviews. We didn't use focus group discussions, and then we went in to produce only descriptive results. So if you look at the current slide, you realize that in terms of the chips, their functionality, it varies from 67% to 100%. Some of them are doing very well. And for us to determine functionality, we had a 5-point question. Do you have service providers? Do you have a structure? Do you have a particular staff like the CHO? And so on and so forth. That gave us this particular one. The next one we wanted to determine was, are they able to provide basic services? So when you are sick for one particular illness, can the CHIPS compound provide that? And realize that it varies from the 86 CHIP zones. It varies between 33% to 100% in our work. And then ANC attendance. When you go there because of pregnancy related, again, we have seen some improvement, and then 67% to 100%. What was very interesting is that almost all the CHIP zones reported that the community health volunteers are active. They are actively involved in all the things that we do. Now, the characteristics of Gen Z, gender, equity, and social inclusion. If you look over there, the target is supposed to be 40% for the project we're implementing. But when we did the assessment, we found out that all of them nearly missed it, because the average is 31%. So our target of 40% was not met in that area. And it ranges between 27% in terms of female composition on the committees. Then we had what we call minority groups. Minority groups here addresses the component of equity, that for some people based on geography or geographical location, context, some individuals become minority within a certain area. So I come from Nabrongo and I live in Tamale. So in that context, I am part of the minority people. And then we looked at that one and realized that it ranges between 0 to 6%, and the average is only 3% of minority groups form part of the committees. That means their views are not sometimes captured during the committee's assessment. We'll look at the next slide that talks about the training. So we went to the CHIPS zones and asked, have you been trained on GENSI related? And out of the 86, only 14 of them told us that they have received one form of training or the other for gender, equity, and social inclusion when they are preparing their activities. Now we look at the health workers themselves, the health workers who are supposed to work with these committees. Are they also trained? And then we can see that, yes, they've been trained, but there's still room for improvement. Only 8 of the CHOs said they have been trained. 2 of the midwives confirmed that they have been trained. And then it goes down. But more community health nurses were trained. For those who are not working with Ghana Health Service, there's a slight difference between a community health officer and then a community health nurse. Not every community health nurse is a community health officer. Our conclusion is that the assessment shows that there were still some gaps, particularly in terms of the responsibilities, the roles of the committees. We also realized that in terms of gender equity and social inclusion, they are lacking behind, and therefore there's more work ahead of us. In terms of recommendation, we are saying that equipment, and the earlier presenters came up that in terms of resources, in terms of equipment, sometimes there are delays. So we had asked them to know the type of equipment they had for providing services at the CHIPS level. And then we found out that most of them don't have the basic equipment to do that. Then there's disparity in terms of the services they deliver. And we recommend that there's a need for the CHIPS zones to standardize the sort of services they give when people come to the place. And then community engagement is very, very important. If we want people to utilize the services that we are providing as health workers, then we should always have them right at the beginning of the conception of the idea, so that when we are going to implement, we implement it with them, and then we can have better sustainability. I thank you for listening to me, and these are our friends.
I told you this was going to be a very interesting session. The next presenter, I told you this was going to be a very interesting session, is here. Thank you very much.
Good evening. Let me say that what I'm going to share with you comes from the same work. Prof. Adokia and myself worked on this project, so the data is coming from the same source. He focused on the functionality of the CHIPS zones. In my presentation, I intend to focus on the community health management committees, trying to look at the committees, their composition, do they know their roles, how are they composed, are there GENSI issues pertaining to how the committees are constituted, and by extension, how is this affecting their work? And then we'll look at whether they have capacities to use the community scorecard, the committee members. And if they've been trained to use a scorecard, how they've actually been able to put it to practice by way of using the assessment using the scorecard tool to then plan, develop community health action plans, and whether those plans are mounted on the digital platforms for monitoring. So basically, I will be doing a lot of skipping because the basic information will be the same. So let's move on. Oh, sorry. Okay. Yes, so by way of introduction, the government of Ghana has made great strides in strengthening its health system. Its commitment to achieving universal health coverage is anchored around the National Health Insurance Scheme and the community-based health planning and services. Martin has talked a lot about the CHIPS, so I won't go there. And we know that at the district level, we'll have a three-tier structure. Prof. Bauer in his presentation talked a lot about that. I will not waste time on the health delivery structure at the district level. This is the system, the system at the district level. Our emphasis in this presentation is based on the community health committees. So how did we get into doing this work? The USAID Quality for Health activity called Q4H project gave us a grant, a small grant, to support the Ghana Health Service in building capacity of frontline health staff and the community health management committee so that they can support the system. So in order to be able to do this capacity building work effectively, we decided to conduct an assessment of CHIP zones and frontline health staff, as well as the community health management committees, to see where in the project districts, 6 project districts in Northern Region, where they stand in terms of their understanding, especially the committees, their understanding of their roles, and then whether they appreciate and value inclusive approaches to ensuring that everybody living within the community has a representation in the committee, and also to find ways to see how they can appreciate the community scorecard, the Ghana Health Service tool for assessing health facilities, whether they can actually use it to conduct the assessment. And if they use it and they generate evidence from using it, what do they do with that evidence? Are they able to use that to develop community health action plans? And then whether those plans are mounted on the digital platforms. So the method basically is the same as I said. In terms of data and how we went about collecting the data is the same as Prof. Adokia said. Yes, so by way of results, we are looking at the community health management committee members, whether they have been trained on their roles and responsibilities. And the data we have is pointing to that. You see the colors and the bars, the assigned roles, whether they hold regular meetings, whether they keep minutes, and whether they act on minutes decisions, when they hold meetings and they take decisions, whether they act on them. So all this constitute their roles and responsibilities. So we assess that. And there's variance in terms of which of these that they've actually grasped well and which they haven't.
We also looked at how committee members received training, how many of them received training in the use of the community scorecard. The community scorecard basically is a tool that allows a group of group members to use the tool with given indicators to be able to assess a health facility. So that's the community scorecard. In this particular assessment, what we found concerning the number of zones, CHIP zones that received the training is shown there. How many of the members received the training? Time training was conducted. All this is important to inform how we roll out our capacity building program. And then we were also interested in knowing how many of the committee members did not receive the training at all, and who actually provided them the training. Because depending on who is delivering the training, there may be differences in the way they package the training. So we're particular about that. And the organizations that are involved in providing training on community scorecard methodology include the DHMT, the Regional Health Directorate, and Q4H project team members. We also have organizations and NGOs in Northern Ghana, Savannah Signatures, and NORSAG, who have been working in this area. And this is the outcome or the findings we made from that. Now, we looked at how CHIPS staff and CHOs, the officers, how they've also been trained on the utilization of the community scorecard. So this is what we found. Yes, quite a good number of them have received training, but there's also clear evidence that in some of the districts, a good number of them have no training on the use of the community scorecard. The Community Health Management Committee members, to be able to conduct their assessment using the scorecard, they will have to do that with the CHIPS zones frontline health professionals. So this was something important for us. In terms of how they have had the experience of using the scorecard to conduct facility assessment, this was the outcome of data, the results of the data we found from that. A good number of them had experience, some didn't have any experience at all. In terms of uploading the assessment outcome-driven community health action plans on the DIMS-2, this was what we found. We looked at it in terms of mounting it at the DHM, at the district level and at the facility level, and this was what we found. So a good number of them reported that they usually will have to send it through mental reports to the district to load. As for the CHIPS zone level, it was not always done at that level. So this, by mounting or uploading the plans, they are able to monitor and track not just the committee members, but the health managers at the district level as well as sub-district levels are able to track how the implementation of the plan is unfolding. We also looked at how the plans are mounted on the RAM car, and this is what we found. Also, in terms of mentally report postage through the district health management team and at the CHIPS level. So, to conclude, this assessment reveals significant gaps in CHIPS functionality and agency responsiveness. It indicates a need for targeted interventions to improve community health management committee effectiveness and inclusivity in health service delivery in the 6 areas. Additionally, Martin talked about some of the challenges. So basically, our work for the assessment, the baseline assessment is done. We started a training program, training the Ghana Health Service staff, and then we went down to train the community health management committees after utilizing this baseline assessment. But we didn't complete the trainings, and the new USAID funding stoppage directive has helped the completion of this project. So it's currently suspended. Thank you very much.
Thank you very much, Martin and Dennis. Community health management committees are such a fundamental part of the CHIPS program, but you can also easily overlook them and easily gloss over them. So thank you very much for carrying out this important work. Our next presenter is Haruna. Is Haruna here? After all the presentations, I'm sure people have a lot of questions to ask. So let's receive Haruna with a round of applause.
Good evening, ladies and gentlemen. My name is Haruna Moshi. I am a master's student at University of Ghana School of Public Health. I also work as an environmental health officer from the Ministry of Health, Tanzania. So I'm here to present our study that's titled as Community-Driven Social and Behavioral Change Model, an approach to enhance WASH practice to control cholera outbreak in hotspot areas. This study is the case of the Rukwa region of Tanzania. So by starting with an introduction, we know that cholera is an diarrheal disease which is caused by the bacterium Vibrio cholera, and the disease is transmitted through eating or drinking contaminated water and foods. So according to the WHO, cholera disease, all right, thank you so much. According to the WHO, cholera is caused more than 1.3 million cases worldwide each year, and also is caused more than 143,000 cases, deaths of people annually. Tanzania, as one of the low and middle income countries, is one of the countries that cholera is predominantly. The disease is there, and annually, each year, there is cases of cholera reported in Tanzania. And the most cases are reported on areas which are alongside the lake. As I don't know whether some of us have got a chance to visit Tanzania. It's one of the countries that is blessed with the numbers of lakes, numbers of rivers and ocean. But this blessing is also a problem. So access to clean water, sanitation, and hygiene is a main way of controlling and preventing cholera. But WASH alone is not enough. We also need something we call behavioral change and community mobilization. The problem is the levels of awareness among the communities is still low, especially for those communities who are living in those areas outside the lake zones and the remote areas. The levels of awareness, their behavior is still a problem. This is the reason why the cholera is still there. So to address this, we came up with the community-driven social and behavioral change model to at least try to change the behavior of the community and address the challenge of cholera. The model was implemented in Rukwa region of Tanzania, as I said, into 2 districts, which is Kasi district and Karambo district. These districts we are chosen because they're one of the districts which frequently reported the cases of cholera in Tanzania. This model involved recruiting of those we call community frontrunners. Community frontrunners are those people in the community who has a power and influence in the community. We recruited representative of teachers, representative of community health workers, community development groups, youth groups, local dancing groups, women groups, region groups, traditional healers, chiefs, ward executive officer, artists, and musicians. And then we provided comprehensive training to them on the best wash practice, and we give them the knowledge on the water sanitation and hygiene, and also we provided them skills on how to conduct a best wash practice, with the purpose that after receiving those training, they will go to the community, they will go back to the community and distribute those messages and skills to the rest of the community. This project was done for the period of 3 months. For the period of 3 months, we provided all necessary material to these people, selected peoples, including posters, flyers, and all material needed. So the main objective of this study was to evaluate the impact of community-driven social and behavioral change on addressing wash behavior in the community. The specific objective was to determine the proportion of the community who sensitized during the implementation periods, and also was to assess the change in the household with the improved latrines after receiving wash awareness. And then we explore the change on hand washing practice among the community. We evaluate the habit of treating drinking water after receiving the wash message. And also, we assess the change in wash practice in schools and public places. So, before implementing this project, we conducted baseline survey to get the preliminary information on what is in the community. And then after that, we implemented our project. Methodology used during this assessment, we used the cross-sectional study design. Location was in Kasi and Kalambo, as I said. The number of households we recruited was 127, 18 schools and 11 public places. The data collection method was, we used a semi-structured questionnaire and observational checklist, and data analysis, we use a IBM SPSS version 25 software. So this study was done after. There is a posting after the implementation of the program, and we tried to compare with the baseline study. So after the implementation, we found that the number of community who sensitized was 89.8% of household, number of household, 89.8% of the household were sensitized on the good wash practice. After that, we found that there is a significant change in the number of improved latrine in the community from 28.2% to 74.8% after the intervention. Also, we found that there is an increased change in hand washing facility in the community from 2.4% before intervention to 32.8% after intervention. This is a positive change, but the percentage is still low. It means that more effort is needed to raise up and sustain this change. And also, the number of households treating drinking water changed from 24.5% to 62.2% after intervention. This change reflects the effectiveness of the community-driven social and behavioral change in addressing wash practice in the community. But also, number of hand washing practice after visiting toilet changed from the 2.8% before intervention to the 32.3% after. So we need also effort to raise this percent. Coming to the school and the public places, also there is changes that we observed. The number of number of the school with improved latrine increased to 77.8% from the 0% at the baseline. Same to the public place, increased to 63.6% from 0% at the baseline. Also, there were increase in the treating drinking water at schools. The percent increased to 61.1% from 0 at the baseline. Significant progress. This is a significant progress from before intervention. So during the intervention period, there were no new cases of cholera were reported. Conclusion. This study underscores the critical roles of community-driven social and behavioral change in enhancing wash practice and controlling cholera, especially in those hotspot areas. The model has proven an effective in changing wash behavior and combating cholera. So the focus should be on the sustainability of this model. So recommendation, number one is we recommend to integrate this community-driven social and behavioral model into the national cholera prevention policies. And the second, we recommend the regular training for those community frontrunners because the main agent of changes in the community. So we have to provide regular training to them and empowering them with those necessary materials. Also, innovative wash infrastructure, as most of the community, they are living on most of the area where cholera erupts are from the community that has low level of economy. So we have to think about the innovative wash infrastructures which are cost effective and the community can afford. But also community engagement. We should also integrate mobile health technology, especially in collaboration, in assistance with this model. We can add the community health, mobile technology because what I know nowadays, most people in the villages and other places, they have a mobile phone. So we can use this as an opportunity to be sending them messages to remind them on the importance of wash, improving the wash, importance of good wash practice on controlling cholera. But also we recommend the constant regular monitoring and evaluations. For those health officials who are working on the district should conduct regular assessment of wash practice in the community. So these are the key references, and this is the end of my presentation. Thank you so much.
Thank you, Haruna, for this wonderful presentation. You asked if some of us knew Tanzania. Maybe you have to make a way for us to go because I really definitely want to go to Tanzania. All the way from South Africa, we have Nkosafayo Tembi Nkambule. He's our last presenter for today. So he'll be presenting via Zoom. So shall we, with a round of applause, shall we also receive our last presenter? And thank you for your patience. We are almost at the final stretch. Thank you.
Good evening. Good evening, ladies and gentlemen. I don't know if I'm audible enough.
Yes, we can hear you. I think you can go ahead
All right,
now. You have 15 minutes to present.
All right, thank you. All right, good evening, ladies and gentlemen. My name is Ngosaphanga Mbule, and I will be presenting to you my study entitled Community Understanding and Patients' Experiences with the Ward-Based Outreach Teams Program in Lesedi Sub-District, Gauteng. The study I did with my supervisors, Tlohelo Malachi and Professor Jane Goat for my MPH at the Wits University. So this is going to be the outline of the presentation. And as introduction, global leaders committed to attaining health for all by the year 2000 during the Alma Ata Conference in 1978. However, now, more than 3 decades later, this has not been attained due to various reasons, including the hospice-centric setup of primary health care. Hospice-centric PHC excludes a substantial amount of people from care and results in gross inequities between and within countries. According to the WHO, over half of the world's population does not have full access to essential services due to social and economic factors that put them on the margins of the health system. Therefore, other systems that bring services to where people live and work are needed. So then in a subsequent meeting, in a subsequent PHC conference held in Astana, global leaders committed to upscaling community-based primary health care, that is, integrating it with facility-based care to bring services to where people lived, because it had shown that hospice-centric primary health care was not working out. So South Africa is one of the countries that experience high disease burden and a decline in life expectancy, especially around the 2000s due to the HIV pandemic. And the government called for re-engineering of primary health care in 2011 to improve access, coverage, and quality of services. So the WABOT program, which is the program I'll be presenting about, is one of the 3 streams that were implemented by the government in 2011. So the WABOT program is the South African version of community-based primary health care, which functions mainly through CHWs and NESTM, and a team of support by a professional nurse, environmental health officers, and health promotion officers to serve in the communities they live in. So the WABOT offers a wide range of promotive, preventive, and a limited scope of curative services. However, the program has been suboptimal in achieving its objectives. So CHWs are an important cadre in the health system to bridge gaps between health facilities and communities in resource-constrained areas such as South Africa. However, as mentioned, the program was not able to meet its objectives due to various reasons, such as poor supervision, limited equipment, and trainings for the CHWs. However, majority of the studies that have investigated this program to improve it have focused on the CHWs, the nurses, the supervisors, facility staff, and no work has been done to get the perspectives of the patients and community members who are the recipients of care and equally important stakeholders in the system. Therefore, also their views are important in order to get a holistic picture of the program in order to improve it. So therefore, the study aimed to explore how the community understood the program, and also to get the experiences of the patients with the program, and also to explore the factors that facilitated or impeded a positive relationship with the program. So this was a multi-case study which involved 2 teams. It was a sub-study under a larger study called the Batlehomedi study, the caregiver study. The caregiver study was initiated by the University of the Witwatersrand to implement community-based primary health care in South Africa. So it was in 3 phases. First, it was the situation analysis, and then a 14-month capacity building exercise was began, and then now we're at the evaluation phases of the community-based primary health care model. So it took place in the study took place in one of the 3 health sub-districts of the study being health district. And the primary study included the CHWs, their supervisors, facility staff, and key informants. However, for the objectives of the study, I focused on the community representatives and the patients. The study involved 10 patients interviews as well as 10 community representatives interviews. For the patient's purposive sampling was used, whereby when a patient was referred to the clinic, that patient was recruited for an interview to get their experiences with being treated by a CHW in the community as well as going to the health facility. And then for the community representatives, snowball sampling was used. Data were collected using a semi-structured interview guide for both the community representatives and the patients, and the interviews were audio recorded. Data were analyzed thematically, and transcripts written and interview notes at the end of each interview. So the findings will be presented using the 3 study objectives. With regards to the community's understanding of this program, they understood the program as a primary health care outreach program which functioned mainly through CHWs, as they had seen the CHWs in the community delivering chronic medication, especially to the elderly, doing adherence, ensuring adherence to medication, and also dictating and reporting outbreaks in the community. They were also vital for health education and promotion of healthy lifestyle. Also, their understanding, they said the program was ineffective and inadequate, especially because they viewed that the CHWs spent more time at the facility other than being in the community. And also, they compared it to a program, a home-based care program that had previously operated. And so they found that in comparison to that program, the CHWs did fewer activities and were mainly focused on HIV services, and that their care was not comprehensive. Now moving on to the patient's understanding of the program, they also said that this program was an extension of the clinic, especially because the CHWs were able to follow them up when they had been referred to the health facility, and to ensure that they were adhering to medication. They followed up on under 5 immunization and did a lot of community outreach. However, there was variation in the satisfaction with the program. This was mainly because the community members had varying access to the CHWs. Some only said they only saw the CHW once, and others reported that they were seeing their CHW daily. So that spoke to the issues and supervision and allocation of the work. Also, they were not happy and reported that the CHWs mainly asked questions and were not able to render services, but referred to the clinic, and which was their point of disappointment with the clinic. However, others spoke well about the CHWs and said the CHWs were caring and understanding, and this really mainly dependent on the exposure to the CHW. So moving on to the factors that facilitate or impede a positive relationship with the ward. So in the sites that employed local CHWs, the community was happy with those CHWs and said they were able to open up more about their health issues versus strangers. And also in the team that had active collaboration between the CHWs and the local clinic, the work was easy and the patients benefited. However, those were the factors that impeded the positive relationship. There was lack of community engagement at inception of the program. So the community was not told that the home-based care project that was operating was coming to an end and that new CHWs were coming. So because of that, the community did not receive well these new CHWs. And also, they complained mainly about the non-comprehensive services and that the services were very limited and only focused on specific issues such as adherence and immunizations. Also, there was lack of resources. There was lack of transport for the CHWs to get to the community members. You find that they get there during the day around 12 and as early as 3, they need to go back. Also, there were no working equipment, which is why they mainly referred to the clinic. So the community felt that they were not effective as when they started. Also, there were administrative issues. There was the clock in and clock out system whereby the CHWs had to go to the facility first and then also at the end of the day report back at the facility. And this was time consuming, especially because there was no transport for this up and down. And it led to them spending lesser time in the community. Also, the patients reported issues of inability to maintain patient confidentiality and privacy. So in conclusion, the WOPET program was able to extend care from the clinic to the people in the community. However, because the program had many challenges, especially those that were centered around lack of equipment, the program was viewed as less effective and inadequate in meeting the health needs of the community, especially in Site A. So for community-based programs to be effective, the services have to be comprehensive and be able to reach the most deprived areas of the community. So the recommendations from the study, especially for the Gauteng Department of Health, is to prioritize the hiring of local CHWs, because in the site where the CHWs were from within the community, there were not much complaints as the CHWs were already there and spent more time in the community versus the ones who hired CHWs from outside the community. And also better reporting and accountability systems are needed because the clock in and clock out at the clinic was presenting many challenges. And also there were issues that they stated around not being welcomed by the facilities staff. The CHWs were not welcome, so there's also those issues to be explored around the facility staff being more welcoming and collaborative with the CHWs. Those are the references I used for my presentation. This is the end. Thank you.
Thank you very much. I think one more round of applause for the presenters and for ourselves for staying true to the program. So we've had two very insightful presentations on community health management committees, one on cholera and one on experience with ward-based outreach teams. And we have about 15 minutes for questions. And I think after the responses from our very interesting presentations, we can call it a day. So if there are any questions, I think we welcome them. Okay, someone has a question. Do we have a microphone? Yes, someone has a question here.
Okay, thank you very much. I want to just ask my lecturers one question.
Okay.
Professor Martin and Dr. Chiraura. So now that USAID is now saying they will not fund the program, they won't fund it anymore. I don't know, what are some of the sustainability issues you'll be bringing in? Because you've already started doing the training. Now there are no funding anymore. What is the next course of action? Is it that Ghana Health Service will now take on whatever you have done? And what are the procedures, the trajectory in actually ensuring the sustainability of what you have found out from your project. I want to ask my sister, the South African, online.
Okay.
Can I ask?
Yes, please go ahead.
Yes. Midway in her presentation, I think I may have, my mind may have gone somewhere. But I want to know, it's like in the findings, she was more particular, or she emphasized more on the barriers, the obstacles, the challenges. Yes, I wanted to know whether in the course of action, were there any enablers, were there any facilitators that you could point to, that you can build on along the way, and not just only the limitations? I don't know whether you get the question.
Yes. Do we have any more questions? Yes. Dr. Yim is...
Yes, thank you. I think the first two presenters, I wanted to ask, I think the first one, that when I was listening to the gender concept and then the 40% target, my question is that were there cultural reasons why we were not supposed to pass over 40?
Yeah.
Thank you.
So any questions? Yes.
Okay, thank you. I think it's a learning process. I only want to find out with the CHMC, the community of committee members, was it fixed? It's like he said 15. Were they fixed? And what exactly is the composition? Yes.
Okay, so I think that we can pass the mic to Dr. Martin and Dennis to respond to those questions. Afterwards, we can have
Yes.
Tembi respond to her question.
Thank you very much. On what plans are in place for sustaining the program? We were, as part of the implementation, we were already engaging the district assemblies to see how they can factor in the committee's work in the budgets of the assemblies. So we are going to continue with this process with the project districts together with the assemblies to see how that can be done. We also, we are hoping that the president's directive that programs that have been funded by USAID and are currently suffering should be prioritized for funding support. We are hoping that it will become reality, and if it actually happens, we'll be able to finish it up. We've gone very far, so we hope that there will be a window to complete the project. Then on the composition of the committees, the chief's policy has already outlined how these committees should be composed. The challenge, as our colleague here referenced, has to do with the cultural issues in our communities that doesn't allow some persons to be part of the committees. And part of the training that we were providing is supposed to help address this gap. But there are actually complex and deep-seated cultural issues that makes it very difficult. It's not just being part of the committee. For example, in certain communities, even if you bring the women on board, they just become part of the committee without necessarily having a voice. They just sit in there, they don't talk, because they don't feel that they have to talk when their husbands are talking. Yes. So those are some of the issues that we assessed and were guided by in developing or rolling out the capacity building program that we did. Thank you. I will let Martin answer the other question.
So thank you. On the question of the 40%, The main beneficiaries are usually women and children. So ideally, women should actually be the committee members. That is the ideal scenario. But in practice, what do we see? Women are always left out, or they volunteer to stay away. And they volunteer to stay away because when they join, there are other implications for being a member. So this was just a modest cutoff point that can we move it from, let's say, the 27% closer to half, but let's start with 40% as the minimum. But if it's possible, we are hoping that in future it will change, because the approach we used was that out of the 15 membership, anytime there's a need to replace, then don't replace with a male. So for example, if somebody dies or somebody travels out and you're going to replace, then look for a female. If not a female, look for a minority group or look for somebody who is under 35 years. So the intention is to gradually replace them to a percentage or proportion that is realistic and sustainable. Thank you.
So Thembi, I think that was a question for you on whether there were enablers and facilitators. You seem to provide more information on the challenges and barriers.
All right, thank you, Chair. Yes, there were a few facilitating factors. So my study under the third objective had 8 themes, and only 2 were enabling factors, and that was the hiring of local CHWs, because they didn't need transport and were always readily available in the community. And then the second one was active collaboration between the community healthcare workers, the facilitative staff, and the local NGOs that worked in the community.
Okay, thank you very much for your quick response. We have a few more, maybe 2 or 3 more questions, then I think it's almost 5:20, so we can close exactly at 5:30. There's one question from the back. Okay. And then after that, we have Padang.
Thank you so much. I would like to know from Prof. Adokia whether this community health scorecard is only to be used on the nurses, the work to assess the health workers, or is to be extended to other areas? And when the results are found, what do they do about them? Thank you.
Okay, can we please pass the mic to Dr. Padam?
Thank you so much. So, in fact, I wanted to ask exactly that question, especially this time that we are trying to move from policy to action, so that doesn't become just something that ends with research. But then I'll leave that and then now move on to Haruna, who looked at
cholera.
Yes, cholera. I realized that. So after the baseline and then the intervention, which was largely
successful.
Yes, successful. But I realized that something like latrines, they were increasing latrines in both schools and in the households. But the intervention looked like more of, it was not something that involved, establishing this, it was just of behavioral change. But some of these things like latrines, that increase is something that requires some capital or something else. So I wanted to find out what could have accounted for, if there are changes in hand washing, that is understood. But if now latrines are increasing in schools and in households, is there something that was done that was not captured probably in the study?
Okay, thank you very much. I think that Prof. Adokia has a missed call, 2 questions. So I think after addressing the question, the Haruna will also will respond to the question. So please, Prof. first.
Thank you very much. The community scorecard is not meant for assessing only health workers. It has a 9-point indicator. And the intention is that for continuous improvement in terms of benchmarking what they've been able to achieve over a period of 3 months. So for instance, when they conduct the assessment, before they conduct the assessment, the committee members, if all the 15 are there, that's fine. But then they co-opt community members and persons who utilize the services should join to conduct the assessment. The first indicator talks about compassion, that is about the health worker. So they want to find out, if you come to the health facility to receive services, how do you perceive the health worker in terms of compassion? So that is the only indicator that deals with the health worker. The remaining 8, some talk about medicines, the pharmacy, do they have stock, and so on and so forth. So the health worker part is not like that. And then 2, after they've done the scoring, it is not so conclusive that they go ahead and upload what they've done. There's an interface where you engage the health worker, and then you will discuss the results. So for instance, when we were on the field, there was a report where we were told that the nurse is disrespectful. And the reason for saying so is that they had come and she was rushing to leave the facility. Later on, when they engaged her own child, she too, her own child was hit by a motorbike. So even though she's supposed to provide services to save life, she was also rushing to go and save her own life. So after that, we agreed that they should engage, and then we'll come back after 3 months. Not we as the research team, but they, the committee members, to reassess. So please, it is not something that is for health workers or to attack health workers. But before the scorecard is displayed, the health workers are debriefed. They give their inputs before that document is then uploaded onto the RAM card. So it's both parties that agree before they do it. Thank you. Thank you.
Prof. The Ghana Health Service is implementing the scorecard. We've been able to cover about 30% of the country. We've got a grant from, and I'm just adding to sustainability. We've got a grant from France, about $3.8 million, to try and train a lot of people. So I asked her how many they were training in where? Northern, okay, just because the work was done in. And she's saying that they are going, the grant will allow them to train about 115 CHIPS compounds, 3 CHMC members each for this will be trained in the next 4 years. I mean, it's across the country, but in the next 4 years. So these are sustainability concepts. So Ghana Health Service is still going on. So even though the research is going on, we are using the results of some of the research to write grants and proposals for it. So even though USAID has withdrawn from the research, we are looking at France also, and they are also supporting us. So this is the way it's going. But it's usually at the community level, and it's not to, like Prof says, assess the wrong of the workers. It's a perception in the health system, but that is not the idea. The idea is weaknesses of the health system that we should all come together and work at it. And these people, you can have a private conversation with Mr. Ziga and who in their districts are doing it at a very high level, where the communities are building buildings for them and so many things. Thank you.
Thank you very much. So we have Haruna respond to the last. He will probably be the last person to comment, and then we'll call it a day.
All right. Thank you so much for the nice questions. One of the things that we identified during the baseline survey we did before starting the implementation of the intervention was that most of the community, they will not have toilets, but not because they are poor to construct toilets. It was just a matter of the behavior, because some of the household had good houses, but no toilet. It means that they seem the toilet to them is not something which is valuable. So the second issues that caused the number of toilets to be low during the baseline was the, most of the community, they look on these influential readers. Some readers who have given the power to read the community also had no toilets. So when it comes to the community, you go to the community and tell them to construct toilet, they say, oh, we can't construct toilet because even our chairperson doesn't have toilet. So one thing that we did to remove this perception was to make sure that those readers, first, they construct toilets. And this was through the enforcement of law, because the community has a law, there is a law within the wards, within the district. So the first was to enforce this law that every community reader should have toilet. And then after that, we recruited those readers and providing them training, and then they go back to the community telling them that it's important to have the toilets, because even as now we have toilet, we have seen the importance of having toilet. So from that behavioral change efforts, we succeeded also to increase the number of the community of toilets. No any fund we provided to the community. The only fund we provided to those representatives. We provided fund to those representatives, and the fund was provided by the UNICEF to enable them to distribute a message and practice skills in the community. Thank you so much.
Thank you very much for quite a response. So the presenters who have not registered, please, we kindly request that you register right after here, and the mentees as well. On behalf of Prof. Bauer and the team, Ghana Health Service team, presenters and everyone, we want to appreciate and thank you for coming early in the morning and sticking with us throughout the day. In the morning, in fact, when we started the session, I wanted us to jump small and turn small so that we wouldn't sleep, but it wasn't necessary. It has been quite engaging and very useful. So thank you very much. Let's receive Dr. Pell. Thank you very much. Tomorrow, we are starting exactly at 9 o'clock in the morning. And we want everybody to stay to the end, because there's a networking session and there's a reception too at the end of tomorrow's session. So it's going to be quite engaging, a lot more formal engaging. If you haven't taken somebody's number yet, I think that gives you a perfect opportunity to take their number and to engage further. So without much ado, I don't know if I can say a little prayer to close the session. So let me give you a indulgence. Father, we thank you for such a wonderful session. We thank you. When we began with you. We pray that may you make the program successful. Indeed, it has been very successful, and we are grateful to you for intervening. Tomorrow, again, we commit the program to your hands. We pray that tomorrow will even be better. These are many other things we ask through Jesus Christ our Lord. Amen. So thank you very much, and see you tomorrow, and all the best.